Right. Good morning. I would like to welcome all you to this exciting webinar organized by a Yorkshire BMA Consultant Committee, where we have very distinguished speakers who will be giving the insight about health inequalities and discrimination within NHS. Speakers today include Sir Professor Michael Marmot, Dr. Chan Nagpal, Anton Emmanuel, Professor Mala Rao, Ms. Prina Israr, Roger Klein. And after the first section of the webinar, at the end, we have a roundtable. We'll be joined by Mr. Martin Barclay, Chief Executive of Mid Yorkshire NHS Trust, Mr. Peter Redding, Chief Executive of North Lincolnshire and Gould NHS Foundation Trust, Mr. Stephen Ames, who is the independent chair of Humber Coast and Vale Health and Care Partnership, and Mr. Jagtas Singh, who's the trust chair for Coventry and Warwickshire Partnership NHS Trust. If you have any questions, you will see depending upon which device you're using, you will see a icon with a question mark on your screen. Please do use that and ask questions. We'll try to answer the questions either at the end of the talks or before we start the roundtable, if possible. I would like to introduce our first speaker, who probably needs no introduction. It's Professor Sir Michael Marmot, who is a professor of epidemiology in University College London. He is also director of the Institute of Health Equity at the University College Department of Epidemiology and Public Health, and he's advisor to the WHO Director General on social determinants of health. Sir Michael, the stage is yours now.
Thank you. I decided to spare you a PowerPoint. I have lots of PowerPoints, but I thought I would speak. I'm not going to talk about the NHS. Other speakers will. And indeed, the NHS Race and Health Observatory produced an excellent report this week with the King's Fund about ethnic differences, racism, and the NHS. So I would refer you to that. As I am obsessed with, will talk about the social determinants of health. And my starting point is that health tells us a great deal about the functioning of society, and health inequalities tell us a great deal about inequalities in society. So, for example, when I commented on the CRED report, the Commission on Racial and Ethnic Disparities, I pointed to Public Health England and the ONS showing the astonishingly high mortality from COVID-19 in Black African, Bangladeshi, Black Caribbean, Pakistani, and to a lesser extent, Indian. And when those data were published, I was on the BBC, and the health minister was asked what he thought about it, and he said he was terribly concerned, and people from different ethnic groups should wash their hands and practice social distancing. And I was asked, what did I think? And I said, that's good advice. And we should deal with structural racism. So then the question is, structural racism in Britain? The CRED report said in Britain, no, nothing like that here. Maybe in the United States, maybe elsewhere, but in Britain, no, of course not. Well, much of the evidence has come from outside Britain, of course. But when I looked at the health data for COVID, for mental illness, for maternal mortality, for outcome of pregnancy. I said, there's no question that what we're seeing is the operation of something systematic. The question is, what is it? I had a very interesting experience. I chaired the commission of the Pan American Health Organization on equity and health inequalities in the Americas, North, South, Latin America, and the Caribbean. And when we produced our report, I went to the National Institute of Minority Health and Disparities in the US, and the director, Dr. Perez Stable, said to me, I heard you speak in San Francisco 10 years ago. You're talking a different language now. I thought, well, that's quite good that I had one new idea in 10 years. What I said in San Francisco, as he reminded me 10 years earlier, and in a way I said it in my 2010 Marmot Review in England, I didn't draw attention to anything specific about racial differences. I said we should focus on socioeconomic differences. And by implication, much of in the US, the black-white differences, I thought, could be explained by socioeconomic differences. And he said, you're now talking the language of racism. And I am. Throughout the Americas, what we saw was that people of African descent had worse health than people not of African descent. We also saw that indigenous peoples had worse health than non-indigenous people. And that was a very consistent pattern from Canada down to Chile and Argentina in the South, right through the Americas, a very consistent pattern. And we had to pay attention to structural racism and colonialism. And these ongoing colonialism, our First Nations Canadians said you can't understand the poor health of First Nation Canadians without recognizing ongoing colonialism. So I came armed with that insight from our commission in the Americas, looking at the data in England and these astonishingly high mortality figures from COVID-19. And as I said, that I look at everything through a health lens. And if we see this health disadvantage, that must mean social disadvantage. The Race and Health Observatory had a seminar on this topic. And at that seminar, I questioned myself. Well, I said that Raghi Mali from Cambridge had questioned me. He said, if I showed you that health in some respects was better in different ethnic groups, would you say that was evidence against structural racism? And I said I had to question my original assertion. He was right to question me. Now, I pointed out that in the US, there is the so-called Hispanic paradox. People of Hispanic origin, in general, have longer life expectancy than non-Hispanic whites. We would never argue that that was evidenced against prejudice. We know there's a high degree of prejudice against Hispanics. You only had to listen to the former president on a daily basis to know how much prejudice there was. Now, I think much of the Hispanic paradox, perhaps not all, is a healthy migrant effect. And we need to ask ourselves the question when we look at the ethnic differences in this country, how much is it a healthy migrant effect? How much does it transmit to the next generation. The problem with being an academic and asking yourself questions and being a bit self-critical is a journalist from one of the establishment newspapers, establishment means right-wing, telephoned me and said, we're publishing a story tomorrow saying that you have withdrawn your criticism of the CRED report. I was just checking with you. And I said, no, I have not withdrawn my criticism of the CRED report. She said, but you said that at the Race and Health Observatory. No, I didn't. I was criticizing me. I wasn't withdrawing my criticism of the CRED report. My criticism stands. There is structural racism. We know it. The CRED report documented it. It just chose to ignore its own evidence. And for those who might have been at that seminar, I showed, for example, the evidence of disadvantage in the school system. Black Caribbean children are 5 times more likely to be excluded than their white peers right across the country. The CRED report said that homicide rates, yes, there is an excess among people classified as Black, but that can all be attributed to deprivation. So I went back to the figures they'd cited, actually came from the Home Office, and it was rubbish. If you divide areas by the most affluent and the least affluent, the absolute difference, the absolute excess for Black compared with white homicide is bigger in the more deprived areas. So it's not all due to deprivation. This was misusing evidence to try and make a preconceived point. I was in a way arguing against myself, saying, look, if the evidence doesn't agree with my point, then I have to be self-critical. I have to examine the evidence in more detail. That's not saying the CRED report got it right. It didn't. It got it wrong. I think there is a big question. When we look at the ONS data on the high COVID-19 mortality in Black African, Bangladeshi, Black Caribbean, Pakistani, and as I said, to a lesser extent, in Indian, what we see is more than half can be attributed statistically to living in deprived, crowded areas and other socioeconomic characteristics. And for the Bangladeshi and Pakistani groups, prior ill health. Interestingly, not for the Black African and Black Caribbean. Does that mean, well, this isn't race, it's socioeconomic disadvantage? And my response to that is twofold. Firstly, I think of social determinants of health as the causes of the causes. So the social circumstances that lead to more proximate causes. And racism can be a cause of the causes of the causes. So why are some ethnic groups in situations of greater disadvantage? I think structural racism in the education system. And it starts at the beginning of life, as we've said, with experience of pregnancy and childbirth. The police, I think it would be very difficult to argue that there's no evidence of structural racism in the police. Forgive the double negative. The evidence is pretty clear. I think the police accept it and they recognize it's something that they have to deal with. So one kind of question is, to what extent can socioeconomic disadvantage be explained by structural racism? And then, to the extent that there are other things going on, it's not all socioeconomic. What else is going on? And that comes back to Eliseo Perez Stable's comment to me. I think there are other things going on. And there's been a real debate in the US, and I think it's time for that debate here, as to whether you should look at race explicitly or just deal with socioeconomic disadvantage. The Economist newspaper did a big feature on race, and it was quite good. Not surprisingly, they came down on the side of, well, don't deal with race, just deal with socioeconomic disadvantage. I mean, it is true that for every dollar a white man in the US earns, a black man earns 60 cents. And that hasn't changed much in 30 years, probably much longer. So reduce socioeconomic disadvantage, reduce inequalities socioeconomically, and you will benefit African Americans because they are clustered in the more disadvantaged sections of society. And then the question is that all you need to do? Not as if that was not a lot, that's huge. But do you need to do anything else? And the judgment is, yes, you do. That is not enough. And it's very clear from attitude surveys, and I say the US has done much more than this, much more on this than we have in the UK, and we need to do more. But it's very clear from surveys that if you put to people a policy, polling, put a policy and say it's to benefit people of social disadvantage, A, or B, say it's to benefit Black Americans, the general respondent will respond more negatively if it's to benefit Blacks than if it's to benefit people of social disadvantage. Seems to me there's a lot of work to be done. That you can say, well, that's not structural racism, that's individual prejudice. Well, yeah, but where does individual prejudice on that mass scale come from? So there's a lot of work to be done to say that, yes, we do need to deal with social and economic inequalities. That would make a huge difference certainly to some ethnic groups in this country. But that's not all that we need to do. As I said in the two examples that I quoted, school exclusions, Caribbean kids, much more likely, 5 times more likely to be excluded from school. Homicide rates, crime rates, quite apart from the day-to-day experience of people from different ethnic groups, which is eloquent testimony. I mean, I've been talking from the data, which is what I normally do, but we've got a great deal of work to do in this country in recognizing the problem, understanding, approaching, as I'm trying to argue, the evidence with a more nuanced approach than I took initially. Not to say I'm going back on my criticism, I'm not. But we have to be more nuanced in our understanding of the data. And I want to finish by departing from the data in a way. Was it the week before last, I think, the students of Magdalen College took down a portrait of the Queen from the common room because they said she was associated with colonialism. and a minister, I think, showing what we teach students about if you get a reflex hammer and you bang it on somebody's knee, the knee jerks up. You don't need to exercise grey matter to get a knee reflex. And the minister showing about as much cerebral activity as a knee reflex said, oh, this is absurd. And the president of Magdalen College showed a little more understanding. He said, it's remarkable how easy it is for students to provoke people if they set out to do it. And so the nature of the discussion in this country is more like banging a reflex hammer on someone's knee and getting a knee-jerk reaction than it is of consideration. And again, I think our politicians have taken a leaf out of the American book, and they think if they can turn this into culture wars, it'll redound to their advantage. I think that's extremely unhelpful. We don't want to have culture wars, woke, non-woke, silencing, non-silencing. That's not the issue. We want a humane society that treats everybody with equal dignity. And we need to understand what's going on. And if people are not being treated with equal dignity, related to their ethnic background, their religion, disability, sexual orientation, it's a stain on our society. It's not helped by banning culture wars. We need to look at the evidence. We need to have humane and sober discussion. And the BMA is to be thanked for promoting this discussion among sane, civilized people who want society to improve and health inequalities to be diminished. Thank you.
Many thanks, Prof, for an excellent insight into structural racism. And I understand you have to leave after this talk for your earlier commitments. Chan, do you have any questions for Professor Marmot? Do you have any comments on his talk?
Well, I mean, I first wanted to say that it's an absolute honor to have Sir Michael here. He has contributed so much in our understanding of inequalities across society. And I also just wanted to say, Ahmed, we should all be very proud that Sir Michael was a past president of the BMA, and we are forever appreciative of the year that he contributed so much to the BMA as well in his presidency. But yes, I'm very happy for others who may want, because we've got a bit of time, may want to ask Sir Michael any questions. But it's always a privilege. I'm proud to be able to speak after him at this conference.
I have got some questions lined up here. Do you want me to go through them?
Yes, Shirley, please.
Yeah. So I've got a question here from Karen Saunders. It says, so the CRED report is and was not evidence-based. We understand this. Is there now an opportunity for Sir Michael Marmot and Professor Tricia Greenall and Professor Malarao, Professor Anton Emmanuel and Dr. Nagpal and all the others eminent speakers at this superb webinar this morning to write an evidence-based report which addresses the issues in a genuine evidence-based way? Would be fantastic if this could be taken forwards, please. Your comments on that, Sir Michael, please.
Yeah, well, the NHS Race and Health Observatory has published a report this week that relates particularly to the NHS. I think we do need to go further to build on that and think much more about the social determinants of health and race and ethnicity. There may well be a case for a different report. I mean, the frustrating thing about the Sewell report, when I commented on the health chapter, I said there's much that's good in this. It acknowledges the importance of social determinants of health. It produces data and evidence. Good. I always like that. It acknowledges the fact that the BAME, which I didn't use this morning, classification covers up differences. It somehow, I mean, it's useful to the extent that people are prejudiced against anyone who's different. But I didn't use it. I talked about Black African, Black Caribbean, Bangladeshi, Pakistani, and Indian. Asian, I could talk about too, but they were not at high risk for COVID. And some of the counter instances I actually took from references that the CRED report included. I think they just misread them or misinterpreted them. So it's not that it didn't have evidence. It approached the issue with a prior position, as we all do, and they allowed their prior position to skew their view of the evidence. Now, you know, I'd like to say, as I said, to repeat, I've changed my view. And I would change my view based on the evidence. My view was it was all socioeconomic. There wasn't space for an extra category, and based on the evidence and the argument. And forgive me going on at length, but when we were doing the American Commission, and one of our commissioners was a First Nations Canadian, and and two of her colleagues who are professors in public health or social science, First Nation Canadians. And after one of our meetings, the three of them, let me boast a bit, they thought I was worth educating. They thought that my ignorance could be reversed. So that's my boast. I'm not boasting that I was ignorant, but it wasn't terminal. They thought it could be retrieved. And I was saying, I'm caricaturing my position slightly. I understand your problem. I've got this model of how social determinants of health work, a conceptual framework, and that helps me understand your problem. And they said, no, you don't. Your model's partial. You've left out what it means to be a discriminated group within a successful society. You've left out relationship to the land, the importance of tradition. You've left out, they said, structural racism. And so we need to have these discussions. We need to be open to new learnings. And yeah, it might be time for a new report.
Thank you very much.
There is there's quite a lot of questions actually.
Right.
So
I'll try not to talk
one more
such-
question, relate.
yeah, we'll try and get through as many of them. So Tal Mahmood, I'm presuming is a GP colleague, said that they love the work that you've done. So much so that they've set up work groups at their GP practice aligned with each of the chapters in the report, testing different methods. They're testing different methods to reduce health inequalities. And the question they've asked is, what interventions do you think would be most effective to try on the ground?
Well, I'm delighted to hear what they're doing. And I'd say each of those domains that I talked about. When I was president of the BMA, we produced a report on what doctors could do and to address the domains that I'd identified. And we said that education and training, seeing the patient in broader perspective, anchor institutions, working in partnership, and advocacy. And these are all things GPs could do. Now, to take specifics, early child development. Actually, it starts with maternity, maternal and child health. We know there's very little dispute about the disadvantage of different ethnic groups through maternity. Maternal health and child health is a clear instance of disadvantage which I think we can attribute to structural racism. So starting there, their voyage through pregnancy and childbirth, the early years, absolutely vital. And here, social disadvantage has a big role to play. We know that single parent families in poverty, children have a big disadvantage. Single parent families not in poverty, the children don't have the same disadvantage. It's not just the fact of single parenthood, it's the fact of the poverty that tends to go along with it. And services make a difference. Now, closing 1,000 Sure Start children's centres over the last decade doesn't help. But for a GP practice, working in partnership with others devoted to the early years can make a huge difference. At the other end of life, adult social care is absolutely vital. And it's a scandal what's been happening to adult social care in this country. But again, it's a vital area where doctors can work in partnership with others.
Another question from Penny Ballinger. Do you think that there is a hierarchy of structural racism that impacts on health? And do nomadic communities tend to top the list of groups affected?
I don't want to give a glib answer to an important question. It is an important question. I think there's not just a hierarchy to structural racism. We need to look at history and culture as well. And nomadic groups certainly have been discriminated against for a very long time. And as one of my colleagues pointed out to me, we should talk about processes of exclusion, not excluded groups. As she pointed out, excluded groups sounds like exclusion is a property of the group, where it's the process of exclusion that we should focus on. So gypsies and travelers, after I did my 2010 Marmot review, there was a representative of the gypsy and traveler community who followed me around. And she said at every opportunity, she said, "There's nothing about us in your report." And she was right. It was slightly annoying to be followed around, but she was right. There wasn't anything about, and you could argue not only have gypsies and travelers been excluded, I'd excluded them from my report, not consciously. I didn't say we're not going to deal with this. We didn't have any data. We didn't have systematic data. So I don't know about the hierarchy of racism, but there are certainly some groups that have suffered more than others. And the other thing to say is that, you know, in the US, when Republican senators have said, we're not a racist country. Look, Barack Obama was president, Kamala Harris is vice president, and they didn't seem to understand that if people overcame prejudice, if they overcame hurdles, that didn't mean there weren't hurdles. So people can overcome hurdles, and we know that in general, the people of Indian background in Britain are more likely to have education than whites. They do better in the educational system. Some Chand will talk about discrimination within the NHS, and it's there, there's no question. But the fact that people can overcome discrimination and prejudice and racism doesn't mean it didn't exist. It just meant that they had to work harder to overcome it.
Many thanks, Professor, for your inspirational work and your great talk. We can probably stay the whole day listening to you. but I know you have to leave. And once again, many thanks for finding time for us today. And thank you very much.
My pleasure. My pleasure.
Yeah.
And I'm sorry I do have to leave.
Yeah. Right. May I now invite our next speaker, Dr. Chan Nagpal, who obviously needs no introduction. He is the chair of the BMA Council. He is also board member of the recently formed NHS Race and Health Observatory. Dr. Chan Nagpal is going to talk about race inequalities and the medical profession, what needs to change. Thank you, Chan.
Okay, good morning, and can you see and hear me first of all? Yes?
Yes, we can.
Fine. I'll just bring up my PowerPoint, show my screen in just 1 second. Can you see my slides?
Yes,
Ahmed?
we can.
Yes, we can.
Fantastic.
Yes.
Okay, well, first of all, thank you so much to Ahmed and the offices of Yorkshire Regional Council, BMA, for putting together this really important event with excellent expert speakers, and I'm looking forward to hearing all of them. An honour to follow Sir Michael. And I'm going to be speaking specifically about the medical profession and race inequalities in my role as the chair of the British Medical Association UK Council. We represent medical students and doctors of all specialties, of all fields, across the UK, over 160,000 of them. And we've put a lot of work in recent times trying to understand the experience of ethnic minority doctors and issues around race equality. So I'll go on to my next slide. And I'll actually start with the Commission for Race and Ethnic Disparities report, the CRED report, or the SEWL report, as many of you will call it. And as you may recall, the CRED report makes a very bold statements by saying that the NHS is a success story with significant overrepresentation of ethnic minorities in high status professional roles. It also says, that describes the NHS as having the onward march of minorities into positions of power and responsibility in medicine. Now, it's certainly true that the ethnic minorities are overrepresented in percentage terms, with nearly 4 in 10 doctors in the NHS coming from ethnic minorities. Excuse me, I've lost my slides. Give me 1 second. How do I get back in? I can't. Yeah, I think I've, yeah. So I'm back on. It's certainly true that 4 in 10 doctors in the NHS come from ethnic minorities. And also about 28% of all international medical doctors in the NHS come from overseas. But what I'm going to go through in my presentation is rebut these statements, which I think are inaccurate and misleading, and do not do justice to the very adverse experiences of our ethnic minority medical profession and healthcare workers more generally. So we know that ethnic minorities have been an integral part of the NHS since its inception in 1948. We have had ethnic minority doctors over those decades working and in effect propping up the NHS. But if you talk to many of those doctors who've been here in the 50s, 60s, 70s, you will hear stories of how they worked in jobs that no one else wanted, did jobs with rotas that were 1 in 2 and very grueling that no one else wanted to take. GPs who worked in end of terrace houses where there was no investment available, but they still managed over the years to serve their communities. And in the case of GPs, many of them who now have, through decades of efforts, created some fantastic large medical centers. So they have been part of our NHS, but they have worked very hard. And in fact, what I will also describe, had to experience very unfair levels of disadvantage. And as Sir Michael also said, where we have seen success, where we have seen doctors reach top positions in the NHS, they've actually done so by swimming against the tide, not even on, not with the tide. And that has been, I think, the feature of our health service, and something that really does need to change. Now, I'm going to just share some facts here. This is not opinion. These are facts. That when you look at the medical profession, there is differential attainment in the pass rate of doctors of ethnic minorities in terms of postgraduate examinations. This pass rate gap is very stark when you compare UK trained doctors with international doctors, and you could argue, well, maybe that's because of cultural factors. But what's more concerning is that UK trained white doctors pass postgraduate exams at a far higher rate than UK trained ethnic minority doctors who have actually been schooled here, they've trained here. And what Catherine Wolf at UCL has shown is that the evidence is not related to any lack of ability. And that just, this face validity would tell you that doctors from ethnic minorities are extremely hardworking, and I said earlier, probably work harder to achieve. So there's something about the system that she has identified, several cultural factors, including exclusion and lack of feedback, that has resulted in this disparity. But that is a disparity that affects their career progression too. So when I then look at career progression, it is a fact from the RCB survey, Royal College of Physicians survey, that you're less likely to be shortlisted if you apply for a top consultant post, and you're less likely to be offered that post if you go to an interview. So we've actually got, again, a disparity. And there's another disparity, which is you have an overrepresentation of ethnic minorities in a grade called the SAS grade, the Staff and Associate Specialist grade. And many of those doctors have not been able to, where they wanted to, achieve a consultant's post. We know there's lack of diversity in the NHS leadership, with only about 10% of NHS board members coming from an ethnic minority. When you then look at, again, progression and pay, there is an ethnicity pay gap where white consultants are paid nearly £5,000 more than those from ethnic minority backgrounds. There's also a Clinical Excellence Award gap. For those of you who may not know, Clinical Excellence Awards are awarded both at a national and local level to doctors who achieve excellence, and it also significantly increases their pay as recognition. And ethnic minority doctors are far less likely to apply for these awards, and they're far less likely to be awarded these awards. I'll show you a slide in a minute, but also we have Professor Marla Rao speaking this morning, who's written an excellent paper on this, and I hope she'll be talking about that as well. We know that there's racist abuse by patients on NHS staff, and we know sadly that that has increased. When you look at our regulator, the CQC, when it comes to general practice, there's been real concern that they are rating practices with ethnic minority partners inadequate at far higher levels than practices that have white partners. And again, when you look at the evidence, a lot of it is around lack of context and judgments that are perhaps not addressing the constraints that many of these practices are facing. We've all heard about the differential complaints that affect ethnic minority doctors in the workplace, with doctors of an ethnic minority background being twice as likely to be referred for disciplinary processes in the GMC, but also now some evidence and something this week that came to light that there are processes within the GMC itself that mean that you may well be getting disparities if you're an ethnic minority doctor in terms of the judgments found against you. This is a slide that just shows the scale of difference in these excellence awards. And as you can see, that only 22% of ethnic minority doctors applied for these awards compared, and in terms of success, sorry, my screen's gone. In terms of success, you can also see that you're far less likely to be awarded an excellence award. So there's a significant disparity in this process. Now, in terms of the experience, what do ethnic minority doctors experience in the NHS? Well, actually, there are inequalities from the day you start medical school, and our own evidence has shown that ethnic minority medical students are 4 times as likely to report bullying and harassment, and that affects their education, it affects their experience, so much so that the British Medical Association's Medical Student Committee have produced an excellent charter for race equality that is now being adopted in the vast majority of medical students. So these are the sorts of changes that need to occur so that you embed that culture of equality within medical schools from the outset. If you're a doctor, you're twice as likely to report bullying and harassment, and you're about 2.5 times more likely to say you would not feel confident to speak out about safety concerns, and more likely to say that if you do, that you will feel that there will be blame against you for the very issues that you're trying to blow the whistle on. We also know that when you look at experience, that larger numbers of ethnic minority doctors don't feel included. They feel excluded. They don't feel that they're part of a team working arrangement. And when you put all of this together, we also know from the GMC's own wellbeing report that if you have these negative experiences, it affects your mental state, it affects your clinical performance. We also know from the work of an excellent organization, Civility Saves Lives, that when you're bullied, when you're harassed, when you have that sort of adverse experience, there's a 61% reduction in cognitive ability and your performance. And if you put that together, you can see that these negative experiences can affect the work performance of ethnic minority doctors, can also lead to that negative spiral of then error and blame and then being excluded and not supported. So we all know about moving on to the pandemic, and we all know that the tragic figure that 85% of doctors and about 60 odd to 70% of healthcare workers more widely who died from COVID-19 were from an ethnic minority background. And the majority of those had come from overseas. But this is not even mentioned in the CRED or Sewell report. And neither did the report look at the factors that may have led to this. But this statistic goes well beyond statistical variation. It goes well beyond the fact that 40% of ethnic minority doctors are in the NHS, because this is nearly 9 in 10 doctors affected. So we've tried to look into the reasons for this. And the BMA carried out 13 tracker surveys about every 3 to 4 weeks throughout the pandemic. And we've had tens of thousands of doctors reporting snapshot experiences. And what this has shown is that ethnic minority doctors, especially during the first wave, when, as you will remember, PPE was short, were twice as likely to report not feeling protected from COVID. They were twice as likely to say they felt pressured to see patients without adequate PPE. They failed fit testing at a higher rate because the masks for the FFP3 masks that require a tight fit were often designed for white male face shapes. That was also an issue for females, and also some PPE wasn't suited for those of certain cultural or religious backgrounds, such as Sikhs or Muslim women. When they were risk assessed, they were twice as likely to say they were not satisfied with the risk assessment process. They didn't feel that adequate adjustments were made. And when we asked them about speaking out during this pandemic, when in fact we were all at risk and are still at risk, they were 3 times more likely to say they were afraid to speak up. And when we asked them, why were you afraid to speak up about not having adequate PPE, they said they thought they would suffer recrimination or it would affect their career progression. And during this pandemic, they were even more likely to report bullying and harassment, including from senior leaders within their own provider. In terms of well-being, ethnic minority doctors were less likely to say they were able to take full breaks. They were twice as likely to say they had to cancel leave in order to work during the pandemic, were more likely to report depression, anxiety, and other mental health issues, and they also were less able to access well-being support. So you can see the picture of the experience during the pandemic for ethnic minorities. And this case study, which some of you will have heard me talk about before, I think really encapsulates the experience of ethnic minority doctors and the structure experience. And Dr. Peter Tunn was a neurological rehab associate specialist at the Royal Berkshire Hospital, who last year on the 23rd of March, during the height of the first wave, was very worried about working in a ward without wearing any PPE, because that was the policy at the time from Public Health England. We had shortages of PPE, and he knew that his patients could easily contract COVID in a hospital where there was COVID circulating. And he asked, and he put an email out to his management and said, I would like to be wearing a mask because we may get infection in this ward. His manager said, sorry, the policy is you cannot wear a mask. He accepted that. He put in an email his concerns, continued, but he didn't challenge. About 4 days later, 4 patients on the ward contracted COVID. A week later, he was infected, went into intensive care. 3 weeks later, he died. Now, I'm not divulging anything confidential. His story is published in the media. I spoke to his son, and what was clear to me are the structural factors that do prevent ethnic minority doctors to challenge the issues around management within such organizations such as the NHS. And I think it is an important learning point that highlights perhaps to some degree why we have seen increased numbers of ethnic minority doctors who have been affected by this virus and sadly died as a result. I also want to just say that international medical graduates or doctors from overseas do deserve special mention because they suffer significant additional hurdles in our health service. You know, actually emigrating to another country is traumatic enough for any person, but leave aside that to come into our NHS, the actual application process is pretty inflexible and complex. But not only do you come to another country to even find housing, set up a bank account, employment advice, whilst you're doing all that, you are entering an NHS that is extremely challenging for any of us who've actually been trained in the system, leave aside if you come from another country that has a different healthcare system. And what an ethnic minority doctor gets is a half-day induction at the GMC. That's what they get. And after that, they're expected to, many, just turn up to work and be doing an on-call for on a weekend. And it's not surprising that they then suffer all those things that I described earlier. They feel excluded. They're unable to know how to navigate the system. And when something goes wrong, they're afraid to speak up because, of course, they've come here, many have come here for training, and then they end up getting caught into that negative spiral that can also result in disciplinary processes. And they're experiencing all of this, many of them, on their own, away from their families, away from the peer support all of us take for granted, where you can turn to others for advice and advocacy. And so as a result, we at the BMA are now putting, and I've certainly been supporting this alongside many of other colleagues, some dedicated work to support overseas doctors, IMGs. And we have now elected champions across all specialties in the BMA or branch of practices, junior doctors, GPs, SAS doctors, consultants, so that they can act as champions. So the BMA itself forms policy understanding the needs of our overseas doctors. Our own employment services are now being tailored to be more specific, to be more tailored in terms of the needs of our IMGs. And also we're campaigning for changes to induction and so forth. We have a dedicated newsletter, and this is certainly a piece of work and a program of work that is going to be major in the coming years. During the COVID pandemic, we put a lot of effort to make sure that those from overseas doctors have been can be looked after. Certainly, we ensured that they could stay in the UK, especially if they were, for example, caught out by trying to sit a PLAB exam when that was cancelled during the pandemic. We successfully lobbied with others to exempt overseas doctors from the health care surcharge. We extended visitor visas. We've supported doctors being able to work additional hours without compromising their immigration status, and I could go on. So there has been huge amounts of work put in to support our overseas doctors during the COVID pandemic. But it certainly is not enough. At the moment, we have an issue that many overseas doctors have adult dependent relatives from other countries, and those relatives cannot be looked after in many cases and need to come here so that doctors working and healthcare workers working in the NHS can be with their parents, and the current immigration rules actually do not allow this in any easy way. We've also been calling to end charges for hotel quarantine for many overseas doctors coming here. For many of them, paying £2,000, nearly £2,000, is unaffordable, and just seems to be an inequity. Certainly, nurses do not have to pay that charge. They are given quarantine when they come to the work in the UK. In the BMA, we've also set up a national Black and Asian minority, ethnic minority forum, and that's been driven by regional networks. So we have recognized that ethnic minority doctors do not feel able to speak out. They feel very isolated. What we've now done is given voice through networks throughout the UK and the devolved nations, where thousands of ethnic minority doctors in the BMA now talk. They meet in meetings, and they have representatives at a national forum. And this is the sort of change we believe that organizations need to provide, so that you really can give legitimacy, voice, and influence to those doctors who have felt historically that they haven't had a voice. Now, we've talked a lot about inequalities in the NHS, and I think it's important to recognize why this matters. It, of course, matters from a human rights point of view, that it's right and fair. But it also is important because we pride our NHS as a healthcare system that treats patients based upon fairness and equality. And I think it is unacceptable if we stand for that when we look after our patients, but don't stand for the same values when we look at our own workforce. But on a more positive note, if we have an equal NHS, it will bring out the full potential and capability of every doctor. We have a system that seems to be dumbing down the potential of ethnic minority healthcare workers to be their best. That affects, as I described earlier, how well our health service can look after patients. It also affects patient safety for the reasons that I described earlier of the impact of negative experience on performance. We also know positively that where providers in certain NHS trusts that have embraced diversity and equality actually have more content and fulfilled staff all around. So it's also the white, the non-ethnic workforce that benefit from a culture that values diversity, and it also results in greater productivity of those organizations. And it's ultimately clearly a no-brainer. This is best for the taxpayer. You get a health service that is the most productive and actually has the best outcomes when you actually allow each of its workforce to be their best. So in summary, we know, and I've described, that the evidence is unequivocal that doctors from ethnic minority backgrounds face structural or systemic disadvantage. They have more negative experiences compared to their white peers. Now, you know, I'm just going to use plain English. If you have structural factors that affect ethnic minorities, that is structural racism, something which the CRED report did not acknowledge, or not acknowledge, said did not exist. Now, you have to recognize this reality if you can tackle it. So in the CRED report, as Sir Michael said, there are some recommendations that make sense, but those recommendations, in our view, in the BMA's view, are process recommendations. They don't go far enough, because what you really need is upfront to start and say that structural racism exists in our NHS. You then need to say, we're going to do something about it. And you need to make sure that all levels of our system acknowledge and is determined to act. And that starts actually from the government. It starts from the messages the government puts out around accepting doctors from other countries and the policies it has, whether it's a welcoming culture or a hostile culture. It's about the government then making sure that those leaders and managers in healthcare providers also understand what the importance of equality in our health service. And that cultural transformation is what needs to happen now, not just processes. And that cultural transformation is one of positive embracing of diversity, where we start to think of the value and the benefit and the added richness we have in a system that is diverse and brings together doctors from different backgrounds. We then need to make sure that we enshrine measures within our health service that can show us whether we are achieving this goal of embracing equality and diversity. That requires starting from the medical curriculum, where you teach this value, but also the clinical training needs to change. For example, dermatology training at the moment only shows rashes and skin lesions and conditions on white skins by and large. And so you need to change the curriculum so that it is culturally competent. We need accountability. And when you look at medical leaders, medical managers, they need to be performance managers probably is again, I think they need to have cultural transformation and performance management to recognize that equality is at the heart and of their work, not just performing to a agenda of service delivery. Induction is central to our overseas doctors. More than half of doctors who join our NHS in any one year come from overseas. And therefore, it's vital that we provide them with the support they deserve. And as I said, at the moment, they're disadvantaged. We need a no-blame culture in the NHS. We are renowned to have a culture that is pointing the finger. And if you are at that lower rung of the ladder where you feel afraid to speak out, you will be disadvantaged. And that's one of the key reasons, as I said, and I described, that ethnic minorities are further affected. The GMC itself has put out 2 targets to end disproportionate fitness to practice referrals and differential attainments. Those targets are important. We need to make sure that those are now delivered beyond just words. And we also need to have systematic monitoring within the NHS of how these barometers of equality are implemented. There are examples of good practice, and I think it's important to recognize that. Those need to be shared, disseminated, and we need to make sure that everyone working in the NHS understands this and is trained to make sure that they abide by these principles. So that's clearly something that needs to happen. Finally, I want to thank you for listening. And if you want to know any more about what I've said, I have written a blog that was published in the British Medical Journal on the lived experience of ethnic minority doctors, which sadly is not an equality success story. Thank you very much.
Many thanks, Chan, for your thought-provoking talk about structural issues within the NHS that we need to tackle. There are a lot of questions, but I think what we'll do is probably we'll tackle most of them during our roundtable discussion in the second section of the webinar. Thank you once again for finding time on a cloudy Saturday morning for attending our webinar. Thank you. And may I now welcome Professor Anton Emanuel, who is the Senior Clinical Lead for the NHS Workforce Race Equality Standard Program, and he's also a professor in Neurogastroenterology at University College London. He's going to talk to us about from data to action, the future of RES. Thank you, Professor. I think you're muted, Anton.
The oldest trick in the book. Thank you very much, Ahmed. Thanks very much for the invitation to speak. And hopefully you can see my slides in a way which is in the slideshow setting. If somebody can just confirm, that'd be great.
Yeah. At the moment, I think you need to go on the slideshow.
Keep pressing. Okay, is that okay now?
Yep, that's fine.
Lovely. Thank you very much for the invitation. And as I'm delighted to contribute to the session and follow such or be sandwiched in among such outstanding speakers who've already given us sort of provocative thoughts about how we go forward, and that's very much the focus of what I'd like to do. And I say this as somebody who's new to this space in terms of working in NHS England, but I've been a clinician for 30 odd years now, and obviously had my own personal experiences, but felt that that was you know, that's what happens. I'd seen it in my parents when they'd come into this country as semi-literate workers, and I thought, well, you know, people don't call me things in the street anymore, but it's disappointing to feel that 40 years since I came to this country as a child, that whilst people may not abuse me on the streets anymore to the same extent, the experience of being in the workforce is really unchanged. I think we should be honest about that. I happen to work in medicine, but actually the experience of this beyond medicine is the same for us. So how is it possible? How is it possible that we can be in a country where people have learned to stop overtly abusing us, whatever they think, but yet we live in a system where it still allows, this is something that you may have seen on social media about a month ago, disgraceful kind of casual email from a colleague who was sending it equally casually to a presumably complicit colleague with a little, little disparaging, hurtful, and actually, frankly, racist and illegal comment there. And how does that happen? Fundamentally, it happens not because these people are bad apples. We can't stigmatize this particular practice nurse and say, oh, she's the bad one, and we should be able to just identify her and discipline her, and that's the end of it. No. This fruit comes from a poisoned system, from a poisoned tree. This is the problem here. And so fundamentally, the reason there hasn't been change between the experiences of my parents and myself has been for that fundamental reason. So when we take action against this, we have to bear in mind, not that we should be patient, I'm fed up with that nonsense, but we have to be aware we're dealing with something particularly thorny. And how is it that we're going to break this down? I fundamentally believe that data is a starting point for all of this. And I'll explain why I believe data is important. I'm sure some of you in the audience will agree entirely, but some of you will take the point of view, will say, well, data hasn't got us anywhere. And I think that's the point. It's about allying data to an action. But let's look at some of the things that are perhaps most eye-watering. There are many ways in which colleagues get discriminated against, by gender, by religion, by sexual orientation, by disability, and by race. And whilst it is still an unacceptably high proportion of people who experience discrimination, you can see that the one ecological aspect which has increased with time, despite and during the pandemic, has been ethnicity. Okay, your race has become a focus to have increased abuse in this year's staff survey. Okay, that should make us squirm in the context of what Chand and everyone else has described of the experience of BME staff disproportionately being affected by this. From the same staff survey, this is looking at disabled staff. There's a little nugget of information here. And you can see if you compare the experience of the different forms of discrimination in disabled staff, the two columns match each other. The one that's strikingly different is disabled staff who are from ethnic background, where it's almost twice as likely. In other words, this whole intersectional thing is amplified by race. Race matters, okay? We have to get this race bit right for all sorts of reasons. There's a moral case, there's an ethical case, there's a legal case, and as we'll try and show you, there's a sort of a financial case. And what is particular about now? Well, again, the Peter Toon story, which resonates with all of us, because it's something about that kind of modest, quiet determination to do your best and do what the system says you should do because they won't harm you, would they? Well, that we have to try and use those horrific events that have happened to our staff that we've witnessed firsthand to try and move from there to actually using that as a legacy to try and do something better. There are colleagues who are in the system in NHSE who are very devoted to doing this, and there's opportunity of baking some good practice into the new ICSs that are occurring. So I think there is a chance for us to try and reboot where we are. So what are the things that have been used to saying, well, why haven't we got there? Why are we still in this problem? Well, the first thing it says is no data. Well, that just isn't true. Chand has presented tons of data. Michael Marmot has spent much of his career in recent years identifying where there are some data gaps, but there is a massive data, and you have to be willfully blind, as the oft-quoted CRED report has been, to find that there is no data to support this. There's no targets been set. Again, that's just not true. Many targets been set. The question is what teeth have been given to try and make those targets mean something. And then we have this really big problem where we've allowed employment to occur in our image. We've felt we're having a good fit for the organization, somebody who's like one of us, who's done all that. And the cliche about the old school tie and the right university and all that, of course that holds, but there's more to it than that. This whole thing about a good fit means that if you don't have representation in the important bodies which make decisions, you don't get people who look like you on the organization. And the system is organized, this structural, big fundamental overhaul of recruitment through these 6 actions. The purpose of this seminar presentation is not to go through these actions in turn, but to say that we're moving from this idea of saying, well, try and do better. Here's the data. You've got this. Come on, you really should do better. You should know what actions to take. To say, look, actually, maybe you don't know what actions to take. We can spell these out by telling you some of the things for which there's an evidence-based way of moving forward, rather than just saying develop a policy and hope for the best. Here's the evidence when it's been looked at in other sectors, in other countries, in other systems, which works. Apply them all singly, the one that's most relevant to you. How do you know which one's most relevant to you? Well, you're used to seeing the res data, for example, come out. You're used to seeing this familiar graph. And I think to myself, when I look at that, if I was an executive in a trust, an organization, how would I know how to tackle this? I look at that and you see that for white staff in the darker colored blue bars, there's a flat line across all the bands in terms of representation. But for the BME staff in the more turquoise bars, you can see that there's a line downwards from band 5. And we need to be able to tackle that by being able to give people what I often use the expression as bite-sized data which allows people to approach the problem by eating the elephant piece at a time rather than devouring it in one go. Now, we do that in part by breaking it down by the kinds of work band. We can do that by saying, look, let's look specifically at nurses and midwives. Let's look specifically at AHPs. Let's look at doctors. Let's look at bank staff. And a very strong direction of travel, this is just data shown for one of those groups, is to try and break that down. So organization by organization, we can say, look, actually in your organization, the particular problem is not necessarily with doctors, it's with the bank staff, or it's with nurses and midwives. We can break it down also by ethnicity, and we should do, and by gender. We know that the experience of Black women in the health service is way worse than Black men, even though that's bad. We know the experience of Bangladeshi midwives, female midwives, is much worse than Bangladeshi male mental health nurses. Let's break it down by the things that allow us to make action and to really develop the point that Sir Michael Marmot made. I think there are times when I'm very happy to lump into the, whatever we want to call it, the ethnic minority category. And there are other times when we want to take action, when we need to split by ethnicity, by work type, by gender, and help use that approach to make change. Because to the point about targets, everyone's familiar with the 19% target that Simon Stevens initially set for NHS England, but then for NHS more widely. And we can look at things like this, and this is a regional data set looking at that, and you say, well, look, good old London, we're hitting 19% for all these senior bands. That's pretty good. And very poor in Southwest. But of course, as you'll all recognise, there's a different population of staff in the trusts and organisations, but also a different population that they feed from in the community. And so we've developed, and I don't want to dwell on this too long, but some of this has made quite a lot of correspondence to us, this idea of a disparity ratio. In other words, once you're in the organisation, whether you're white or BME, what chance do you have to progress? Here's hypothetically, I put this slide in the last minute because I get so many questions about this literally on a daily basis. A hypothetical organisation with 90 white staff, band 5 and below, 120 BME staff, band 5 and below, 6 white staff at the higher bands, 8+, only 2 in this hypothetical organisation, BME. So the progression for white staff is 15:1, for BME staff 60:1, and the ratio between those two is 4. So the disparity ratio in this hypothetical organisation is 4:1. It should be equal. Whatever your population in the background, once you're in there, you should be able to proceed. And we can show that this disparity ratio is especially eye-watering in the clinical grades. Half our organisations have a disparity ratio where you're 3-fold less likely to progress, despite, as Chanda said, the fact that, for example, 38% of doctors are BME background. So it tells you really how awful it must be. And we can, I don't want to explore this data in detail in this session unless it comes to the questions, but the point is that we can try and use different metrics to get better understanding that we can see that we can look at regional profiles. So that back to London, that 19% actually isn't that impressive. The ratio on average in London organizations is 4.5. We can look at it in different sectors and say, for example, ambulances, just to point out some of the insights that come. Everyone says ambulance service is the most challenged, the most difficult. Actually, they do very well. Once you're in the system as a BME person, you do well. The problem is that there's very few staff who actually get in, so they're not recruiting right or advertising right. But we can help, therefore, to focus where the actions should be for the ambulance services here or in the regions or whatever else. So we can break this data down to eat the elephant piece by piece. As I say, disparity ratios have become something which are now being used and which we would like to, and they're certainly disseminated regionally and locally. Representation matters. Representation matters. So the latest data is that 16% of our board membership in England has 16% of board members are BME. And you think, well, that compares very well with 21% and certainly be a big improvement. But if you compare that to the proportion of staff in that organization, so for example, an organization which has 20% BME staff should ideally have 20% board membership, but where it's 15%, i.e. 5% disparity, that accounts for 2/3 of organizations. And as many as half our organizations have more than 10% disparity between board representation and staff numbers. So this is really not acceptable. And actually, staggeringly, that 16% is about the fact that a third have no BME people in voting positions on their boards. What else stops us progressing? Well, there's discrimination in the workplace. And there is data, and I say I want to use the data to try and move this action forward. We can look at these numbers and say, well, these have changed, these haven't changed. But actually, one simple way of looking at that is to say what proportion of our organizations are outliers to this. And you can see that actually, if you look at that last column, there's still a lot of work to do. So even the metrics which have got better, like the disciplinary, and that's an example of where things can be done right. When you apply evidence-based solutions, you see a sustained improvement in the disciplinary process. So that likelihood ratio has improved. But that still leaves roughly half organizations which are performing disproportionately badly. So yes, there's some little glimmer of light, but we must also root it in the fact that there's still organizations doing badly, and that allows them to target. In some ways, that's almost a good news story twice over, because they can then say, okay, if we're sincere about doing that and accountable, we can borrow the actions that have worked elsewhere and make sure things work better. In terms of subjective data, again, I don't want to go through the data in huge detail, but the point is that there are a significant number of outlying organizations in this. So what are the solutions that are out there? Well, one of the solutions from the government has been this idea that we're going to get more international staff in. But unfortunately, you've got to remember that this is working in a community, in a setting of institutionalized racism, has been, as the point has been made frequently today. There is a structural problem here. If you look at the UK data for this, our feelings of hostility towards Black and brown people is increasing. Okay, it's increasing with time. Unusually for most other countries when it's narrowing. The length of this bar has got worse. Okay, that is a pretty depressing story. And it explains then the context of this kind of horrific tale. Again, I keep illustrating this with these examples from social media and some of the ones that we've had reported to us directly at the RES team, because I think for me, that is one of the directions of travel. We've got to complement our data with these lived experiences. Chanda pointed that blog he wrote, that really excellent item he wrote at the very end of his presentation, and that is massively important in terms of how we can progress this, because actually sometimes data speaks to some people, but the stories speak to another. I'm hoping while I've been saying that, if you read this, if you haven't come across it, and it's really eye-watering that organizations can think this is acceptable. That's the epitome of how structural this is. That not only do they do this and degrade these BME staff day upon day, week upon week, they then felt it as an exemplar of outstanding practice. Give me a break. What other barriers are there? The fact that they'll say, well, there aren't any role models. I grew up in Africa. I'm proudly African in half my origin. And I use this slide of great African leaders in the 60s and 70s, great socialist African leaders who created a network amongst themselves to replace colonialism. And actually, despite the predations of the international systems, have managed to keep their countries until they were then degraded by the progressive march of capitalism. That's a different story altogether. Why am I showing this apart from preaching? Is to essentially say that actually networks work. And when we look at exemplar organizations where there have been strong networks created, they show exemplary action. This is our colleagues in North East London Foundation Trust, Nelft, who have had a policy which way precedes the RES of doing action, and what they've seen is they get sustained improvements in their data. When networks are empowered, created, given time on the boards, given funds to do their work, they produce dramatic changes for their workforce. We can learn from other organizations. This is Ernst Young, I think they do accountancy of some sort. They set themselves a challenge to be more inclusive, set their targets at various things from the board through the HR system through to actual team working and so on, and found that the things that they produce in terms of making money or whatever it is they do and market share and things like that, they got better. So this stuff works. It works. It works. It works. How can we translate that? As I said, we can use exemplars in terms of recruitment practice from other sectors and borrow that. We can generate our data, have redacted data, which is hospital sensitive, but we can put our data into deciles, and then we can rank organizations. These are the worst ranking organizations for matters related to recruitment. And we can rank organizations the very worst. Just to put it in context, on that far right column, the average organization will score 333, the very worst would score 666. And you can see how poorly these organizations perform. So what can we learn from what they're doing wrong, especially when you compare to the very best organizations at the top of this same distribution? Again, instead of having an average of 333, these organizations are doing exceptionally. So what can we learn that's going on so well in these organizations? Working from these exemplar trusts where there's executive teams which want to share their knowledge and what they've done is a key way forward for us. What have they done? When do they do it? How long do it take to take effect? How else do they measure their impact? These are the things we need to understand. And then embedding that into our data cycle, so we produce our data much more nimbly. We'll access the systems which provide that data in a more nimble fashion without any extra ask of the provider. Get their data, find the target, try and find the ways of which policies work best for that, implement that and feedback to us how it works, and then let's look at the data again and do this in a repeated cycle at organizational level and at system level, working through the regions, generating data in a way which is bite-sized and approachable. Again, I've just cut out the names of organizations here, ranking them, producing heat maps, identifying and potentially sharing more widely where it's going well, identifying the targets that you have from these particular indicators, focusing on those, producing maps of data, not just for race. Obviously, I work within an EDI function, looking at the things that matter. I don't want to dwell on all these things, but we're looking at the pay gap since time of employment, since the time of entering the service, not just pay gap by your AFC band, which won't change, obviously, as that Nuffield report showed. But how long have you been in service? There is a difference there. Looking at representation, looking at likelihood disciplinary, looking at, we can do a lot of things which allow us to understand using the data in a more nuanced way to help organizations act at local level and at system level as we go forward. So essentially it's this idea of making organizations accountable and trying to minimize the idea that we can just show people their data and train them out of it, because it's a system that's broken. We have a fundamentally broken praxis, and just changing individuals is not going to change the process. And trying to exert and lean on people who have the influence to do that. This was a very welcome input from the CQC, who the NHS team have been working with. It's a small bend, but one of the first things I did when I came to the organization was to look at the res metrics of our outstanding organization in the system, and they don't perform well. So let's use that data gently and lean on CQC to act more urgently. The GMC have set their targets in the last month. Some of us would say it's not especially ambitious, but it's a target, it's been set. And as I said earlier on, that's kind of the first step to making progress. One of the things that we would want to say is looking forward is this whole idea of international recruitment. And Chandler's touched upon the idea of international trained doctors. Obviously, I speak to the slightly wider workforce. This is data for Filipino staff. And if I can tell you, if you just look at this, 94% of Filipino staff are band 5, 6 and below. Okay, these are people who have been brought into the country, especially since the early years of the Blair government, and who have not been able to progress. Their disparity ratio is about 18 compared to white staff. Okay, that should make us squirm. The point of this slide is to say that policies matter. If you can influence policy, you can change the direction of travel. This just shows what happens in terms of recruitment numbers. So every time there's policy, each of these changes in these waxing and waning graph has related to policies being adopted. I'm a strong believer that if you can do that, you can change the shape of this. You can't change racism overnight. That's never going to be an ambition. But take some of these actions. This is a project ongoing with international staff, in particular the Filipino staff, to try and understand how we can work with them and make things better. Working with bank staff, some terrible data here. The disparity in terms of what bank staff experiences is from one of our pilot sites is just eye-wateringly bad in terms of disciplinary bullying, harassment. So the idea of this in conclusion is that we move using the data, because data matters, but use it in a way which is flexible and nimble and able to influence change and enforcing accountability by working with the bigger organizations. moving towards developing a longer-term strategy based around recruitment and retention processes, based around health and well-being, which is tailored to what's needed. Most of our international staff don't want to have 90 minutes in a gym or an app which tells them to listen to whale music. They want to be given 4-week holiday, 3-week holidays, so they actually travel back to their countries, see their family for the first time in a couple of years. They want to be able to carry a holiday and leave over. They want a culturally sensitive health and well-being program. We should be able to use risk assessment. Why do our BME staff die prematurely of coronary artery disease, hypertension related problems, of type 2 diabetes related problems? We can screen for that. We did that very effectively during COVID to risk assess. Let's do that independent of occupational health. In terms of process, we can do some impact type assessments to see which of our programs work, which don't, and which actions we learn. Use metrics in a more nimble way, as I say, look towards this accountability and developing that, working with exemplar organizations, and essentially have these various themes that I say we will work on. So in conclusion, the idea is to produce this trust level accountability, to work through the regions, to produce our reports in a wider fashion, bank staff, medical staff, in a quicker way, to develop live metrics which allow us to do things, and to gradually instill the idea that actually we can do race stuff because it matters in all our activity. So you've seen this from before. Fundamentally, my belief in all of this stuff is that we have to break the machine. We can't carry on working to this, but we have to do it in a way. And this is Bayard Rustin, one of my many heroes, a gay black man from the 50s, who was a key part of the NAACP, and the Million Man March, for example. And every community which is intent on changing its trajectory of discrimination needs a group of angelic troublemakers. That is our role. Certainly, it's how I see my role. Thanks very much indeed. I look forward to fielding questions now or later. Thank you.
Many thanks, Anton, for a wonderful talk. In fact, a very refreshing talk where you give so many solutions and a way forward. I think what we'll do is, in interest of time, we'll discuss all this in the roundtable. Hopefully, you can join us, and we will have other colleagues. Yeah, thank you, Anton. Now it's my pleasure to welcome Professor Mala Rao, who is a Senior Clinical Fellow at Department of Primary Care and Public Health, Imperial College London. She's a medical advisor to NHS England Workforce Race Equality Strategy and Implementation Team. Thank you, Mala, for finding time for this webinar. The stage is yours now.
Thank you so much, Ahmed. Can you see my screen?
Yes, we can. You probably need to go to the slideshow. Yeah, absolutely.
Right.
Yeah, that's fine.
There we go. Right. Well, I'd like to begin by first of all thanking you, Ahmed, for inviting me, giving me the privilege of sharing some reflections on next steps. I'm truly privileged to follow on from an extraordinarily distinguished group of speakers who've spoken so eloquently on the subject. So I'm going to just talk to you about some very practical issues of how all of us together have a role in translating the evidence on ethnic inequalities in health into action. So, you know, we all know, as we've said already, that history will remember 2020 as a year when two events collided. I am, of course, talking about the COVID pandemic and the murder of George Floyd and the eruption of anger, pain, disbelief, and the resurgence of the Black Lives Matter movement. And as the world started to make some sense of these two apparently disconnected tsunamis, it woke up to the fact that the disproportionate impacts of COVID-19 infection on ethnic minority people, as well as NHS staff, was explained in substantial part by racism, discrimination, and socioeconomic inequalities. And Professor Sir Michael Marmot has spoken so well in showing us the evidence of that. But, you know, happily for us, NHS leaders have been aware of the ethnic inequalities since 2014, certainly in the recent history of addressing ethnic inequalities in the NHS. Where did that begin? It began with the fact that ethnic minority communities across the social gradient were reporting lower levels of well-being than the white population since the ONS started collecting annual well-being surveys in about 2010. And the Public Health England invited me to review the ethnic disparities in well-being and the likely drivers for this. And my review, which I completed with my co-author, Juliet Stevenson, included NHS evidence and set it against this background of what was going on in law enforcement, in media, in education, in employment, and it serendipitously and very fortunately brought to the attention of Parliament. Very fortunately for us, Lord David Pryor happened to attend that launch. He was dismayed. He will say so if he was here today. He was not aware that ethnic minority people had a different experience from his personal experience. And the great thing is, he went away and thought, well, I have to do something about this immediately. And that's how the Workforce Race Equality Advisory Group began. Independently, Roger Klein and others were, Anis Ismail, were speaking to Sir Simon Stevens, who had arrived in NHS England, about bringing in res indicators. And so, here we were with, for the first time since I've been in the NHS for 4 decades, an extraordinarily supportive NHS leadership in Sir Simon Stevens and Lord David Pryor, essentially giving us authority to take forward a deeper dive into ethnic inequalities and doing something about it. So the question is, how have we responded to this? And Anton has has been given us such extraordinary data and reflections on the wider workforce. So I'm going to focus on ethnic inequalities in the medical workforce and in health and healthcare. So we know that ethnic minority doctors face disadvantage throughout their careers. We know that differential attainment by ethnicity persists across all measures of career progression, the entire training pathway, and in all specialties. And it is for that reason that when I took on the medical focus in 2018, having served on the advisory group, the Workforce Race Equality Advisory Group between 2015 and 2018, stakeholders, including ethnic minority senior doctors and all of the organizations that represent us, said, as a priority, you need to build on the successful RES indicators and develop the MRES, the Medical Workforce Race Equality Standard, which we proceeded to do with this extensive stakeholder engagement that you could see on this slide. So, we have this. It's been launched. It's on the NHS England website. You can take a look at it. It was launched last September. It's a world first in monitoring race equality nationally. It is the first step to breaking down barriers to race equality. And it charts all of those things that make a difference to us. The education and development opportunities and performance, career progression, treatment by patients and employing organizations, and the characteristics that Chand spoke about. It will be published annually, and it is already beginning to challenge organizations and staff, including ethnic minority doctors, to contribute to action. So if you look at indicator 1, that charts career progression. And as Chand has already mentioned, you see a big representation of ethnic minority doctors in the salaried doctor grades, not so much in medical directors or among clinical directors. Then if you look at pay gaps, and actually NHS digital data can give us pay gap data, we see the intersectionality, which we can bring in future years when we look at MRES data. The largest ethnicity pay gap is for Black women doctors. If we look at ethnic minority student entrance into medical school, they make up 41%. But if you look at career progression among clinical academics, and we mustn't forget academia, you don't see nearly the same numbers. In fact, it'd be hard pushed to see many ethnic minority people in professorial grades. So the question is, what should be the actions to address indicator one? What practical things could we be doing together? And Chand again has talked about international medical graduates. Here are people who in the newspapers from time to time, they are referred to as highly valuable people who who help and contribute to continuing to keep up with the demands and the needs of the British healthcare system, and yet they are treated like second-class citizens and gap fillers. There is now, happily, an induction program for international medical graduates waiting to be launched. It's staggering, isn't it, that the NHS began in 1948, and we have, as Chand was pointing out, we have never had a proper comprehensive standard induction program. This was priority 2 assigned to me by the ethnic minority stakeholder groups. So we have one, and I'm proud to say that it's an international medical graduate critical review group that helped and co-designed and helped put it together. It's ready to pilot. But look at the kinds of challenges we end up with. The question now is who will host it, who will invest in it? Health Education England, since the fragmentation of the NHS, is responsible for training and education, but it's only responsible for training and education, strictly speaking, of trainees, undergraduates and postgraduates. NHS England looks after and employs people, but understandably does not have the training and education function, and possibly isn't the right place in which long-term investment and hosting of the induction program should happen. So here we have a structural problem that comes from the long-standing indifference to induction. But happily for us, here's a key opportunity for ethnic minority leaders in both organizations to resolve the problem. And we've got Health Education England leaders who are beginning to say, well, it is the first step for international medical graduates of social integration into the NHS, life in England, and beginning on their lifelong learning journey. So we will look after this, and that is just slowly beginning to happen. But the issue of investment remains unresolved. Look at pay inequality. Chand very kindly pointed to the paper we wrote. It was the most, I suppose, deep, in-depth analysis of Clinical Excellence Awards. What we found was Clinical Excellence Awards are structurally racist. You cannot denounce racism and say, well, but let's just keep Clinical Excellence Awards though, because I quite like that. And here's Professor Sir Michael Marmot, who has said to us, only today he's highlighted how divisive pay inequality is and how damaging it is to health. And yet, even amongst us, ethnic minority doctors, is there unity in challenging the system? And it's a question we need to ask ourselves. Let's look at indicators 2 and 3. This indicator 2 was inspired by the Royal College of Physicians' ability to analyze, and it's in this for about 8 years, a doctor's application of consultant jobs, and to see that there is an ethnic variation in likelihood of being shortlisted and likelihood of being appointed. And the number 3, it relates to double the rate of being referred to the GMC and a likelihood of having revalidation deferred. Now, the question, if we want to take actions to address these indicators, is what roles are we playing? Have we asked our colleges to take the lead from the Royal College of Physicians and undertake the same kind of analysis on shortlisting and appointments? Interestingly, at the Royal College of Pediatrics and Child Health Conference only 2 days ago, it looked as if they are beginning to feel the heat of it and say, oh, we better start doing this analysis. What about appointments committees? There will be people in this audience who sit on appointments committees and have senior roles. You have educational roles. You supervise junior doctors. You do all kinds of things, which puts you in a position of influence where you can train ethnic minority trainees to be confident at interview and perform as well as their white counterparts do. So in many ways, this is a responsibility on all of us to get right. Now, looking at referrals, yesterday's judgment was extraordinary. That judges have announced that reported that they fear the GMC is infected by racism. With regards to referrals to the GMC as well, goes on in the GMC, we have a role in challenging these system committees, complaints, to find ways to resolve complaints as locally as we possibly can. What role does the Ethnic Minority GMC Forum play in holding the GMC accountable? What are we doing in asking them to look at vexatious complaints and to actually investigate the trusts who make such complaints where they are proved to be vexatious? Do we challenge revalidation outcomes? Indicator 4 is entirely to do with differential attainment, starting with a difference in the acceptance of applications to medical school and then on to postgraduate training, assessments, and exams. So what are we collectively doing to look at the differential attainment in ARCPs and exams? As Chan pointed out, Kath Wolf's evidence gathering is showing very clearly that the cause is an unequal learning environment. It is not learner deficit. It's not as if Black and minority ethnic students and postgraduates and undergraduates have a learning deficit. It's the environment in which they are taught. But our white and ethnic minority doctors among the trainees, as well as amongst us, the supervisors and the deans and so on, are we working together to resolve this? Or is political correctness getting in the way? Sir Michael alluded to this a bit. People are terrified now of causing offense. How can we get over that to bring about some honest conversations in good faith to resolve these issues? Indicators 5 to 10 relate to bullying from patients, staff, colleagues, relate to equal opportunities for career progression, experience of discrimination at work, levels of motivation and engagement. And Anton has already talked about the doctor who made an emotional presentation at the RCPCH conference 2 days ago. And when I asked some questions about it and highlighted it, there's been a lot of discussion of it on Twitter. And I am staggered because I thought this was one thing that had begun to be resolved, that we don't even have agreed policies on tackling racist abuse from patients, let alone looking at microaggressions from staff and so on and so forth. And they were saying to me at the RCPCH conference and subsequently, the pediatricians have a particular problem because the racist abuse is not coming from the innocent child, but from a parent who is not the person they're examining. So pediatricians are accepting this abuse, continuing to manage children to their best abilities, but beginning to be extremely affected, adversely affected by the regular dose of abuse that they're getting. Why have we been silent about this? Why have senior doctors not brought this to people's attention nationally? And why haven't we worked towards policies that look at how we deal with this complex legal situation? Indicator 11 relates to diversity in national and medical school and academic leadership roles, so deans of medical schools and so on and so forth. And I want to say a word about medical academia here, because this is where there is the most deeply entrenched racism, and discrimination. And it's worst for women of ethnic minority backgrounds who aspire to become academics. The RCP research highlighted only a few months ago that ethnic minority physicians appear to struggle to access research, giving culture of the trust they work in, and their own lack of confidence and skills as key barriers. The Wellcome Trust response to Black Lives Matter it reported on their website that ethnic minority and especially Black applicants are less likely to be awarded their research grants in the UK compared with white applicants. In 2019-2020, 0 Black people got Wellcome Trust awards. And in terms of NIHR and UKRI funding, we don't even have data to see what the breakdown is, but we know broadly that ethnic minority academics are very badly off in terms of receiving funding and being promoted to higher grades. And what we see is a lack of ethnic minority people at the top leadership of academia. And there is underrepresentation even in global health research. So you will find generally it's white professors who go out to places like India and Africa to do research. You don't have ethnic minority diaspora engagement in this because they've never been encouraged to come into those positions. So little wonder then that there are variations in health and healthcare. Ethnic minority people have the greater burden of ill health. The health survey for England, as far back as in 2004, showed us that the health of white English people aged 61 to 70 is equivalent to Caribbean people in their late 40s, Indian people in their early 40s, Pakistani people in their late 30s, and Bangladeshi people in their late 20s or early 30s. Why weren't we shocked about this in 2004? Why didn't we shout about it? Why didn't we research why this is? Had we researched it 17 years ago, would we have seen the disproportionate impacts in the pandemic? And if we look at ethnic variation access to healthcare, the BMJ is littered for 3 decades, 4 decades, with research which has shown variation in maternity, mental health, pain management, cardiovascular services, and the rest. And we have just ignored these issues. Now, we ethnic minority people have to stop, if you like, maintaining that silence. Health research ignores ethnic minority people. We know there's a general lack of representation of ethnic minority contributions and inputs, for example, in COVID vaccination research, which you'll all know about. But algorithmic-based medical innovations are beginning to be approved for use with clinical trials with 0 ethnic minority participation. And this is leading to gadgets and technologies which could misdiagnose and potentially increase health inequalities. And research funders and journals have not used their influence to correct that imbalance. So, in conclusion, just denouncing racism is not good enough. We need to take anti-racist action with time and money invested in it. We all have the power to contribute to it. It isn't about saying, oh, well, these things happen. We're going to say these things happen. We're going to complain about it. And it's up to someone somewhere to bring in the change. We all have the power. We need to be involved in action. And we need to use our power well to contribute to this, because in our spheres of influence, there are things we could be doing. We need white people to be involved in action, and we need ethnic minority people to be involved in all key decision making. And we need to ask for those things to happen. We need courageous conversations and to work to common goals, which might mean, like in Clinical Excellence Awards, to give up some of our advantage so that everybody is leveled up to achieve pay equality or whatever other goal we are going for. White and ethnic minority people need to come together to achieve this equity in the workforce and in healthcare. I'm troubled by that separation and not enough white people coming into this, this kind of movement that we are creating. And I want to go back to where the top leaders, when they saw the evidence, they acted swiftly to give us that authority and invest a little and say, get on and do something about race equality. And I want to go back to that. We have had a dream, support from the top table. We've had a dream situation since 2014 from the leadership of NHS England, leadership of BMA, and we've been given the permission to get on and do things. And we need to, utilize that support we enjoy to be ambitious and transform the health landscape together. So no more silence. Everybody reflecting on how they could act. Let's be ambitious and let's transform the health landscape. Thank you. Thank you for listening.
Thank you, Mala, for a great talk. And I agree, we all have the power. All of us need to get involved, and we definitely need Vitalize, right? Are you joining us for the roundtable? I think what we'll do is we'll take all the questions and discussion at the end of the session. As we are pressed for time, let's have a 10-minute convenience break or coffee break, a virtual coffee break. And at 11 o'clock, we will have Prina Israr's talk about workforce priorities and the NHS People Plan. As we all know, she is the first NHS Chief People Officer. Please do come back around 11 o'clock. See you then. Now I think it's my turn to speak. I'm really humbled to follow such eminent speakers which have come before me. I'll try to share my screen. That's how it works. Go. Right. And can I please check? Can you see my screen? And can you hear me?
Yes to both.
Yes,
Yeah.
we can hear you
Yes.
and see the screen.
Thank you. Thanks a lot. So basically, I'm not an academic. I'm just a simple frontline worker. I'm a consultant in ophthalmology at North Lincolnshire and Gould NHS Foundation Trust, and I'm the chair of the BMA Yorkshire Consultant Committee. So I'm going to share with you some statistics. In fact, these have already been shared by speakers before me, and then we will explore together if there's any credence to this perception amongst some ethnic minority colleagues that the response of the NHS to COVID-19 risk mitigation would have been different if white colleagues were being disproportionately affected by the COVID-19 virus rather than the ethnic minority colleagues. And in the end, I'll share with you some survey results that I have done. When you look at the ethnicity of public sector staff, it is quite apparent that NHS is the most ethnically diverse public sector organization, with over 44% of the NHS staff is from ethnic minorities. Professor Emmanuel has already shown this slide. In NHS staff survey 2020, 13% of the staff reported discrimination at work. And the most common cause cited was discrimination based on ethnicity. Again, Professor Emmanuel has already shown this slide. When we look at the Agenda for Change pay band, we find that ethnic minorities proportion in higher pay bands significantly decreases as we go to higher pay levels. And this is the same case if you look at Agenda for Change pay band in the London region. So, and this was highlighted by Roger Klein in his 2014 report on and he termed it as snowy white piece of the NHS, where he highlighted the absence of Black and minority and ethnic staff at the senior levels of NHS. This is a table from Roger Klein's report of 2014, which looked at nurse managers from ethnic minorities. And he showed that between 2003 to 2012, the proportion of nurse managers in England from ethnic minorities was less than 8%. And in 2019, 7 years later, if you look at the data, nothing has really changed. It was apparent in early April last year that ethnic minorities are being disproportionately affected by the COVID-19 virus. If you look at this graph, which is the ICU admissions in May 2020, which shows that disproportionate number of ethnic minorities were being admitted into ICUs. This was picked up by the media. NHS Confederation in their member briefing highlighted the impact of COVID-19 on ethnic minority communities and the staff. It was all over in the newspapers that why BME people are dying from coronavirus. NHS England asked PHE to start a review to look into the factors which were impacting the health outcomes from COVID-19 virus and why they were impacting the BME communities so adversely. But while all of this was being done, and every day we were hearing reports of ethnic minority colleagues dying from this virus, sadly, nothing was really being done on the front line to mitigate the risk from COVID-19 infections. Nothing meaningful was being really done. And it prompted me to write a blog for the BMA in which I asked the question that do we ever wait for a complete understanding of a disease before we start treating the affected patients, at least with symptomatic treatment? Is it right for the employing organization to wait for results of inquiries and studies to know exactly what is causing these disproportionate deaths in BME population before practical steps are taken to protect them? Of course, we shouldn't have. And I'm lucky that I worked in an organization where the senior management was sympathetic to the concerns of its ethnic minority staff. And we were the first organization, to my knowledge, who had a fit for purpose risk assessment tool, which not only identified the colleagues who are at an increased risk, but also gave practical risk mitigation, protected them from the virus. This is just one of the flowcharts from the tool that we developed at Northern Lincolnshire and Gould NHS Foundation Trust, and this was implemented in end of April, early May, and probably we were the first trust in the NHS to do that. In April, our chair, Dr. Chan Nagpal, wrote to Sir Simon Stevens asking NHS England to develop a risk profiling framework and to conduct risk assessment that take into account not only age, but other factors such as ethnicity, sex, and comorbidities. Immediately after that, a letter was sent by Sir Simon Stevens and Amanda Pitchard, the NHS Chief Operating Officer, to all chief executives of all NHS trusts and foundation trusts and NHS organizations, asking them to do a risk assessment of their ethnic minority staff. End of June, I did a survey of over 1,000 ethnic minority NHS doctors. And what I found was that even at end of June, around 46.5% of colleagues haven't had a risk assessment done. And if they had a risk assessment done, then over 55% of them were not happy with the results of the risk assessment. And this was June, more than 2 months after NHS trusts were asked to do BME employees risk assessments. And we knew at the time that UK probably had the highest COVID-19 healthcare worker deaths in the Western world. So may I ask, would the NHS organization would have responded differently if it were the white colleagues who were being disproportionately affected? I leave this answer to this question for you to decide. So did the things improve? In August 2020, I did a survey where I asked the same question, whether risk assessment has been done of colleagues. And things have indeed improved. Almost 80% of all colleagues have had their risk assessment done. However, when the question was asked, are you satisfied with the result of the risk assessment? Then about 25% of the ethnic minority healthcare workers said they were not satisfied, significantly more than white healthcare workers, which was around 7%. When the same question was asked from international medical graduates, we see again, international medical graduates who are from ethnic minority, around 26% of them said they were not satisfied with the result of this assessment, as compared to less than 6% of white international medical graduates. So it doesn't really matter whether you were from ethnic minority and you lived in the UK, or you were from ethnic minority background and you came from abroad. You had the similar experience. When the question was asked if you have been changing to your work pattern with COVID-19 pandemic, has it been done with your agreement? Then significantly more BME doctors said it hasn't been, as compared to the white doctors. And this was the same finding in the NHS staff survey of 2020, which showed that more BME staff was put on a rota so that they are working in COVID-19 specific ward or area, as compared to white colleagues. Similarly, when a question was asked whether the present work environment gives them confidence to raise the concerns with senior management, again, significantly more BME colleagues said they do not have the confidence to raise concerns as compared to white healthcare workers. When I presented this data to some of the senior NHS leaders, they said it might be because most of the ethnic minority healthcare workers are from abroad. There may be a cultural issues, there may be language barrier. But when we look at the data and we look at the ethnic minority healthcare workers who study in the UK, we still find significantly large, a similar percentage of healthcare workers who say that the present working environment does not give them the confidence to raise concerns. So this debate regarding racism is based upon, there's a lot of evidence, direct and indirect, anecdotal examples, personal views and experiences. And if we are serious in tackling discrimination in NHS, then we must be bold enough to ask the right but difficult questions. What I would really like to know is, what does white privilege, which is no one's fault, what does white privilege mean in NHS? What is unconscious bias within the NHS? So I did a survey earlier this year, asking healthcare workers about their perception and views about racism at the place of work. So when I asked the question, in their opinion, does racism exist in NHS without taking into account patient behavior? 79% of the BME healthcare workers said yes, as compared to 41% of white healthcare workers. And when I asked the question, did you personally experience racism? Again, significantly more ethnic minority healthcare workers said yes, as compared to white healthcare workers. So this slide shows, for me, the most disturbing finding of my survey. When the question was asked, have you experienced verbal or physical abuse from your colleagues based on your race? nearly 19% of ethnic minority colleagues said yes. Please note, this is verbal or physical abuse based on race by colleagues. When the question was asked if you have witnessed racism at your place of work, did you take any action? A vast majority did not. 44% said they did not take any action. And when the question was asked, why did you not take any action? More than 58% of colleagues said they feared the consequences. This is 2021. This is definitely not acceptable. And the minority of colleagues who did take action when they witnessed racism, only in 22% of the cases, they felt that the outcome was appropriate and the situation was dealt with. More than 32% said the issue was not resolved. 13% said the action worsened the situation. And 31% said the complaint was completely ignored or no action was taken. So I really like this saying. It says justice will not be served until those who are unaffected feel as outraged as those who are. That's why I really like Professor Mala when she said that we need vital eyes. If we want things to change, we must have vital eyes. But we still have a lot of work to do with regards to that, because in the same survey, there were some comments. This is a comment which says that witness colleagues in discussion denying white privilege. And they were not happy about the movement schemes that promote equality and diversity, which they feel are unfair to white people. This is a white colleague writing in the survey, I'm seeing racism against white males. There's no active discrimination against whites. So in the end, I would just like to say institutional racism, unconscious bias in NHS, whatever it is, it cannot change until the time NHS hierarchy represents the diversity of its workforce. And we must also remember that diversity is not merely about numbers. You know, it's not all about just getting a black or a brown person into a board or executive. Yeah, it needs to be more than that. We need a leadership which is authentically inclusive. We need a culture that embraces diversity at its core. This discrimination, inequalities within NHS need to be dealt with not just by words or surveys, but by meaningful actions. And as Professor Mala said, this is the most opportune time. You know, there's a will to change things. So let this COVID-19 pandemic be the watershed moment to bringing the meaningful change within the NHS to end discrimination. Right, thank you. Right. Okay. If you have any questions about any of these talks, we'll try to deal with it at the end if we have time. No, it's my pleasure to introduce Mr. Roger Klein, who is a research fellow at Middlesex University Business School, and he's the author of a number of papers, including the report that I mentioned in my talk, The Snowy White Peaks of the NHS. So, Roger, the stage is yours.
Just so you're aware, we can see all your emails at the moment. It is showing to everyone.
Including the one I sent you, Roger, and get it off the screen.
Roger, you're muted, I think. Roger, we still can't hear you.
Please check your settings under audio. Should be an audio tab to your right.
Right, right, Roger. Yes, we can see. Sorry, you don't have any audio. So
If you
We
could
could hear you
exit the
before,
webinar.
Roger.
So while we are waiting, Shirley, do you have any questions that we can pose to the previous speakers while Roger is trying to get his audio back on?
Yeah, so there was a question that was raised for Chand regarding his slide based on the differentials in examinations, and this has come from a GP who said that in the most recent cohort in their GP sector, that they'd found that the majority of people who hadn't passed the exam were from ethnic minorities. However, the RCGP board recently released a statement saying that results showed no evidence of differential attainment. And the question that's been asked is, when leading organizations state that there is no difference in this differential attainment, how do you affect change? How do you make people aware that this is happening, and how can these organizations actually change if they're not recognizing there's a problem?
Hi, would you like me to answer that, Amit?
Yeah. Yes, please. Yes, please,
Roger.
Chan.
Do you
Yes,
want
please,
to wait
Chan.
for Roger?
Please do.
But okay,
Yeah.
well, once Roger's free, please. Yeah, no, I think you've whoever asked the question. Sorry, I've forgotten your name, but it has asked a really important question about something we've known a long time. Is regarding the disparities in postgraduate examinations. The example given, the Royal College of GPs. We are, as we speak now, challenging that view from the college, because we do know that GPs are not, we know that ethnic minority doctors are not passing the exam for certain components at the same rate. We think the factors are structural in terms of the way the examination is set, but also some of those inequalities relate to the period before you even sit an examination, in how much support, learning, inclusivity that doctors from ethnic minorities have in their educational experience until the point of the examination. I can tell you as a GP that my training for my membership largely depended upon my experience with my trainer. Now, if you have if there's evidence that that doctors from ethnic minorities don't get that same attention, that same sense of inclusivity, that same sense of feedback, you will not get the same attainment. That's something that Catherine Wolfe from UCL identified in her research. Is Roger ready now?
Roger?
I've looked at his, if you look at the chat box, organisers, you'll see he's the only one where the mic is greyed out. Actually, he's ringing me now. See if I can help him.
Right. Shirley, I think there were quite a few questions for Chan. I think there was a question, Chan, about this recent.
You may need to disconnect and reconnect. I'm looking at. Are you on a? I've connected onto the mic.
Chan, we can hear you. Can you mute yourself? Yeah, Chan, there was a question on the chat box previously about the BMA view about the recent employment tribunal decision. regarding a case in the GMC and said what the BMA view was about that case. It would be nice to hear your view.
Sure. Can I just be clear which case we're talking about? Because there have been a few recently. I want to be sure that I'm speaking to the right one.
This is the one regarding the consultant urologist,
Yes.
the Kareem case.
Yes.
And actually, this forms part of multiple questions regarding the GMC and their fitness to practice process and discrimination involved in that process.
Sure. This is a really good and important question to ask. As you know, in recent years, and Roger will be speaking about this, we have known that there's been inequality in the workplace in terms of referrals for disciplinary processes, referrals in terms of complaints to the GMC. What this case has highlighted is that up to now, the focus has been purely on the workplace, but the focus has to be on the regulator too. And it seems that from this case, that ethnic minority doctors are not just disadvantaged when it comes to being complained about more often and referred, but when they then get to the hearing, there is inequality. I have to tell you that 3 letters, GMC, send a shiver down the spine of any doctor. You may also be aware, and I can tell you, well, if you're not aware, the BMA is also taking legal action against both the GMC and a trust relating to another very sad case of Dr. Suraj, who committed suicide when he heard about a hearing against him. So this is a matter that we take very seriously. It's affecting the health of doctors. It's wrong and needs to be corrected and addressed head on. And I think this case has given us all the impetus to ramp up the need for reform. And I think Roger is the perfect person talking about this. Because so if he's talking next, he will, because he's researched the whole issue. Roger, are you there?
Yeah, I'm really sorry. I don't know what the problem was. I've come back out and gone back in, and it
Excellent. Good.
Excellent, Roger. But now we can't see you. We can hear you.
Share my webcam. Is that better?
Yes. Right, Roger.
Good.
So, right. Thank you very much for coming. And apologies for your problems. It's probably our fault. We didn't
my competence.
Right. So, without wasting up, so please, do you have some slides to share or?
No slides, but I do have a presentation. So.
Sure. Right. The stage is yours.
Okay. Thank you very much, and thank you for the invitation. I want to start by, I think it says show my screen. I hope that's going to not cause a problem. Can you still see me? Oh,
yes, we can. Yeah.
All right.
Yes.
I can't see you, but not to worry. Okay.
Do you need to share your screen? If you don't, I can take it off for you.
Is that, yes, if you could do that, please.
Okay.
I think it's down to my competence, not yours.
There we go. It's all off now. Okay.
So, colleagues, good morning. Apologies for that. So, in the wake of Black Lives Matter and the impact of COVID-19 on Black and minority ethnic staff in the NHS, there's more evidence than we've ever had before about the impact of race discrimination on NHS staff and the medical profession. As you know, in Yorkshire last month, the Humberside LMC reported that more than half the local staff of Black and minority ethnic heritage working in primary care being the subject of racism in their careers. Around 1 in 6 BME respondents felt their career choice had been affected by racism or discrimination, and more than 1 in 5 said that racism or discrimination affected their ability to train in their career. The most recent NHS national survey revealed that only 1/3 of clinical commissioning groups even bothered to take part in the survey, and within those, just 41% of BME staff felt their organisation provided equal opportunities for career progression or promotion, compared to 88% of white staff. And some of you may recall the recent case where an application for a practice nurse had the words "another Nigerian" scribbled on it alongside her rejection. And there are still major challenges in secondary care. The RCP analysed data not so long ago from 8 years worth of annual surveys, reporting on the experience and outcomes for clinicians within a year passing their CCT. Data showed that white CCT holders applied for fewer posts, but were more likely to be shortlisted and offered a post. And when it came to the likelihood of being offered a post the first time round, 29% of white respondents were offered a post after being shortlisted for the first time, compared with just 12% of BME respondents. And some of you may have seen on Twitter last night that the NHS still defends employment tribunal cases it shouldn't, such as that one reported yesterday by consultant urologist Mr. Karim, which has been rumbling on for 8 years. So, black and minority staff are 21% of the NHS workforce, a higher proportion of the medical workforce. The NHS scours the world for doctors and nurses, but frankly, if you don't look like me, male and pale, you can expect to experience slower career progression, higher disciplinary rates, more bullying, and as Robert Francis showed in 2015, a greater risk of victimization if you raise concerns, as well as less chance of being listened to. The 2019 report by Doyle Natural-Argan and myself highlighted the reasons why international medical graduates are more likely to be referred to the GMC and why IMG doctors risk being treated poorer in other respects of their working lives and careers. And then along came COVID. So a decade ago, Sonia Hutchins and colleagues warned that a future flu-type pandemic was likely to particularly hit BME communities. Government failed to act on such warnings or to prepare for the pandemic when it arrived. 60%, 6 in 10 of the hundreds of NHS-owned social care staff who died were of black and minority ethnic heritage. On the 12th of May 2020, Public Health England researchers reported it was likely that 89% of those deaths were from occupational exposure. And they didn't die because they were working in the most dangerous parts of the NHS. On the contrary, they weren't working in intensive care units. They were working elsewhere. And we know what the main causes of NHS staff deaths included. And they're related to the racialized nature of NHS employment. Poor access of BME staff to appropriate PPE, as surveys by both yourselves and the RCN showed. Greater reluctance of BME staff to raise concerns due to a well-evidenced belief they'd be ignored or fear it will make things worse. Disproportionate redeployment of BME staff into less safe areas, as confirmed by trust data, anecdotal reports, and even an ITN survey. The greater presence of BME staff amongst agency staff, locums, contractors who are sometimes denied appropriate PPE, often deployed to the hotter COVID areas, with some deterred from self-isolating because they're poor pay guarantees, particularly true for nurses. And NHS leaders who are out of touch with the risks that BME staff face because they looked disproportionately like I do. Had the Department of Health and national NHS bodies required trusts to follow the various regulations, management of health and safety at work, regs, protective equipment regs, equality impact assessments, they would have picked up all or some of these risks, but they didn't. They were so detached that the NHS took the extraordinary step of deciding to stop collecting workforce rate equality standard, equality data during the pandemic on the grounds that it wasn't a priority. Then in May 2020, a further major error was made. NHS employers were told to focus on individual health staff risk assessments, which are important, but not on workplace risk assessments to understand the causes of the higher infection rates. In fact, less than half of those individual risk assessments have been completed anyway, 16 weeks after the WHO declared a pandemic. So understanding the causes of what happened in COVID and more generally of race discrimination leads us to know what needs to be done to decisively tackle workforce race discrimination. There's been lots of activity, but it's not been nearly as effective as it should have been. So I'm going to run through very quickly some suggestions. Firstly, EDI must become core board business. You shouldn't be a member of an NHS board if you can't confidently explain to staff, managers and interview panels why tackling race discrimination is important for the NHS and demonstrate what you are doing personally to achieve this. There's some progress on this, and there's more BME staff in senior positions, but for example, I fear it's too slow, and the restructured ICS boards may be no more diverse than the current ICS chairs are, and they primarily look like me again. Secondly, leaders must remember what Robert Francis said in his 2013 report on Mid Staffordshire, where he said, quote, and I'll quote if you don't mind, "There lurks within the system an institutionalized instinct which under pressure will prefer concealment, formulaic responses and the avoidance of public criticism, and an institutional culture which ascribes more weight to positive information about the service than to information capable of implying cause for concern." We have to stop looking for comfort seeking in information, and we have to go problem seeking. Thirdly, boards have to stop signing off action plans on race equality unless those proposing them can demonstrate why they have a reasonable evidence likelihood of working. In considering clinical interventions, we obviously look for such evidence. Why don't we do this on race discrimination? A typical action plan consists of improving policies and procedures, training and some positive action. But the research is clear. In isolation, that will not move the dial in the direction we want it to. That applies to bullying, whistleblowing, discipline, to recruitment and career progression. Training is helpful, but on its own, it's not going to make the difference. Because it may improve cognitive understanding, but is unlikely to lead to significant changes in decision making. Boards have to be proactive and preventative. They have to insert accountability at every stage. For example, adding a BME member to a disciplinary panel may be a step forward, but really the most effective way of changing what's happening in disciplinary processes is for managers to be expected to be held to have an accountability nudge, to be held to account at the point where they decide whether or not there's even going to be an investigation, not by trying to make the investigation fairer later on. Boards, in other words, have to embed accountability. There should be consequences when diversity goals are not met, as they are for any other key performance indicator. Research strongly suggests it's more effective to de-bias processes than to wait for individual managers to be de-biased. That's not to say training is useless, but it has its place. We know, for example, that stretch opportunities acting up secondments involved in project teams are the most important contributor to career progression, but they're mainly accessed still via the tap on the shoulder. Just look at how many ICS roles and leading COVID-19 roles appear to have been filled in that way. Boards and teams have to prioritize psychological safety, where the contribution and the arrival of BME staff is welcomed. There's little point in improving the representation of Black and minority ethnic staff unless we understand that organisations need to be inclusive as well as more representative. And boards and leaders have to model the behaviours, inclusive behaviours themselves, with consequences if they don't. Culture is largely shaped by what leaders do and don't do. Good leaders put themselves in the shoes of others, listen, enable, polish the skills of others, and are honest about mistakes, and they make diversity and inclusion a personal priority. I would say a growing number of leaders do understand that, but there are still many that don't. Primary care is not covered by the NHS staff survey or by the RES. It's not included in the standard NHS contract on race equality. So one of the steps that I think really needs to be taken, I think the BME is calling for this, is that NHS race equality monitoring should be extended in some way to cover primary care. We need some form of primary care res that could shine a light on poor practice and hold practices and those commissioning them to account. We need to address the specific discrimination faced by some groups of doctors, notably IMG and SAS doctors, We have to stop treating them, and they still are often, treating them as second-class citizens. And that should include relentlessly following up the GMC and NHS England's of the recommendation that Doyen Atawalagan and myself made on the disproportionate referrals of IMG doctors and their treatment as outsiders too often. And almost finally, I read, as many of you have done, on Twitter last night of the paediatric service that allowed apparently a family to choose the ethnicity of their doctor and then presented this as a model of patient-centered care. I don't know the details, but if it's true, they're a reminder that we must expect all medical directors, senior partners and chief executives to do what the chief exec of Wigan Writing to the Lee Trust did a couple of years ago. A reminder, a racist patient demanded to see only a white doctor. His request was refused. He went to the local paper to complain and attack the trust. The chief executive told the paper that if the patient returned to the trust, he would receive emergency treatment if he needed it, and then be told to find care elsewhere if he repeated his demand to see a white-only doctor. And finally, it's time to do better on national accountability. It's time the CQC reviewed how it conducts its investigations into trusts and into practices to ensure that BME staff and patients are treated, how they're treated is a core metric, notably in the well-led domain. I really can't understand how it is that trusts, for example, can get outstanding or good ratings if they can't demonstrate they're making progress on race equality. There's much more discussion about NHS racism than there was a couple of years ago. There's been some progress, but it's been much too slow. And now is the time to take decisive, evidenced, not tick box, practical action. And hopefully today's conference is evidence that there's movement in that direction. Thank you very much.
Thanks a lot, Roger. It's really a good fortune that your technical difficulties were overcome and you were able to give us these pearls. Can I suggest that I request all the participants in the round table, can they unmute themselves and turn their cameras on? May I introduce our four new guests in the conference who are going to join us for the roundtable. Professor Stephen Ames, who is the independent chair and lead for Humber Coast and Rail Health and Care Partnership. Can I suggest maybe we can mute ourselves unless we are talking, because there's a lot of echo. Thank you. Mr. Martin Barkley, who's the Chief Executive of the Mid Yorkshire NHS Trust. My own Trust Chief Executive, Mr. Peter Redding, who is the Chief Executive at Northern Lincolnshire and Cool NHS Foundation Trust, and he's the co-chair of the Disabled NHS Directors Network. And Mr. Jagtar Singh, OBE, who is not playing golf this morning because of this conference, so thank you very much for attending. He's a Trust Chair for Coventry and Warwickshire Partnership NHS Trust. So may I first probably ask my colleagues who are in leadership positions within the NHS what they think about what they heard earlier this morning, and how would they increase or how would they change things within the organization. Can I ask Mr. Jagtar Singh to start?
So what would be my wise words? Well, first of all, I think this conference itself, if it was shared, the recording was shared with every single trust board, would drive change. It's been evidence-based, it's been realistic, and it's been absolutely eye-opening. The window of opportunity that you called for is now. COVID has told us that discrimination is structural and institutional. Black Lives Matter has taught us and stopped me as an activist of the 70s and 80s in my tracks. because I thought the Black Lives Matter issues had been resolved after the death of Stephen Lawrence, and the law changes would have changed institutional discrimination. Some of you are members of BAPIO and have heard me speak of BAPIO before, where I ask people to put their hands up if they know about equality impact assessments, equality analysis. I'm always horrified every year. The number of hands that go up are not significant. So the tools for change are not even known by our colleagues and our champions of diversity. The tools of change around the law. Roger made a really evidence-based approach towards risk assessments. The Health and Safety at Work Act that I had to apply when I was a fire officer should have been applied at the start of the COVID. Risk assessments should have been carried out for these type of risks. Why is it that we had to have individual risk assessments when a corporate risk assessment for working in those environments should have been in place? Why did we have to invent masks for people with hijabs and with turbans when these medical, biological risks already existed? I think we've got a lot of learning to be had. So I'm just going to finish on what do I believe are the answers. I often get asked by boards to go in and give them a quick survey and audit. My answers are simple. Structure governance will help you. Strategy with smart objectives will help you. Accountability, in particular of middle managers, will help you. Use benchmarking data to mark progress. Support your staff networks. Listen with intent to act, not listen with intent to reply. Be an echo chamber of diversity in your boards. Coaching, mentoring, reverse mentoring, sponsorship are all great tools to drive change. Never lose hope. Optimism is what you need. Bounce back ability when you get knocked down is really important key. And my final comment, can we do it? I normally ask for a reply. I'm not. The answer is yes, I can. Because if you say yes, we can, it means you want Jack and Roger to do it all and Mr. Chan to do it. When you say yes, I can, it brings us the power of one and everybody galvanizing towards a common goal.
And thanks, Hector. Professor Ames, it would be very nice to have your comments from what you've heard this morning before.
Hello, everybody. Can I just first say thank you so much for inviting me today, Ahmed. I think it's been a privilege and it's been a very inspiring event. And I did like the previous suggestion about how we might utilize what we learned, because I've learned a lot this morning, specifically within our integrated care system. And I suppose it's further informed me about the issues, and I can't, when I'm speaking, I can't let the sort of shocking impact of the survey that Roger mentioned actually had on me when I received it back in April. And I don't want to run through the detail, but the ICS is using that and could use this to advance all of its activities in this area. We will do that. So, you know, my resolve is, you know, is hardened further by what I've heard this morning. As an ICS leader, I again, back to Roger, I am male and pale, and in that late middle-aged group that he's talking about, and I think we should see the ICS movement as an opportunity to address all the things that you've been talking about this morning. So for someone like me, it's about modeling behaviors, it's about being present, it's about using our BME network of networks that we've established to test our policies and approaches across our ICS. We're in the middle now, of course, in this transitional year of setting up new architecture along the guidance. So one of the things that we want to do as an ICS is think through, in co-production with our wider collection of networks, just how we do that in an authentic and meaningful way. So, and there are other things. We know we've got very limited diversity in very senior positions, non-exec and executive level across Humber Coast and Vale. We are doing something about that currently with a programme that we're developing. Other colleagues have mentioned in the conversation, and it's a particular challenge actually, not just in this dimension, but in terms of our middle managers who are sort of squeezed by the big policy issues on the one hand, under the considerable pressure on the other, you know, with the COVID demands and the wider demands of recovery. And I think some of those things about the microaggression and other experiences that came out very starkly in the LMC report I referred to, the risk of that occurring is greater in those circumstances. Therefore, the attention to addressing that through the programs that we're putting in place is even more important. So I could say a bit more, but I think the last thing I'd say, that the big thing about this conference and what you've done in bringing this together for me, I go back to Michael Marmot's comment earlier about a humane and sober discussion. I mean, that's what this is, and I think to mirror this and channel this now from this conversation across our ICS is what I would intend to do. Thank you.
Yeah, thank you for these comments. I just want to make a comment on your comments. I think it's really important, basically, as Professor Mala said, that it's, you know, being white and pale is not a, you know, it's more of an advantage to be here because we need vital eyes. Unless we have people, you know, like you, who think what we are thinking or who share our thoughts, only then things can change. Peter, what your thoughts from this morning?
Good morning, everyone, and thank you very much for asking me to be on this panel. I have to say, I joined not quite sure what I'd learn, because I was involved in the leadership of the first anti-racist campaign literally 45 years ago, when I was a 20-year-old student in Cambridge, and this has been an agenda which has mattered to me all my life. But I have to say, I've been absolutely awestruck by the presentations today, the detail and the messaging. I thought I understood this territory, having been a chief executive for 22 years. It's worse than I thought. I knew it was bad, but it's worse. And I have to say, there's part of me which says every trust board ought to be required to watch the video of this conference, and to do it as a board, not individually, and discuss it. My ICS lead is nodding at that, so maybe we can think about that collectively, Stephen. What do I take from it? Well, I have to say, there was so much today, and I don't disagree with anything that was said. And speaking as yet another white male, I'm embarrassed by so much. What I might just add, first of all, I think Anton Emmanuel's point about doing things in bite-sized chunks is really important, and I think the granularity of your presentation, Anton, was incredibly helpful, and I think then boards need to think about what they can do. The second thing I'd say is that I do think this needs to be much more forcefully part of the performance management of trusts and NHS organisations, and it isn't yet. It's exhortation rather than actually being turned into hard performance management. Now, as a chief executive, you've got to be careful what you wish for when you say something like that. But I think that I know what in the NHS, and I'm afraid sometimes, unless it's actually hardwired into the performance management, boards say yes, we'll do something about it. At the end, when push comes to shove, the hard imperatives of the performance management are what drive them. So that needs to be bedded in. My third thing would be to look at what drives change. And Ahmed, you kindly referenced the work that you and I and other leaders at Northern Links and Gould did around risk assessments last year, and thinking about worked when we mobilised that. There were two things. First of all, I was fortunate to have a medical director and a director of people who were on the same page as me, which was this really matters and we've got to do something. But equally, it was you and some senior colleagues driving things, bringing it to our attention, working with us. And I think mobilising internal forces, if you like, is really important. At Northern Links and Gore, we're fortunate 2/3 of our medical workforce are from BAME backgrounds, and so we have a rich asset there. And the final thing to say is equality matters, inclusion matters, but perhaps we also need to focus on diversity. As the NHS moves into a collaborative world, diversity and leadership is going to be a critical ingredient of success, to an extent that it's going to be far greater than in the past. And I think there's almost a business case for promoting diversity in leadership, not just the equality and the inclusion one. And maybe we just need to speak a bit more about that and press that button too. So there's just a few additional things, but I don't take anything away from what's been a remarkable session this morning. Thank you, everyone.
Thank you, Peter, for these comments. And Martin, what's your take from this morning before we open it to everyone?
I completely agree with both Peter and Stephen that they have been absolutely remarkable presentations this morning. A number of things struck me, particularly Roger's comments about this being one of the key lines of inquiry in the well-led domain of CQC inspections and success criteria. I also want to echo Peter's comment about Anton's presentation. I must say, until I listened to Anton, I had never heard of the disparity ratio before. I was also particularly struck by those tables of trust. And Anton, as Chief Exec, I've never seen that table. I've got no idea where Mid Yorkshire is. And it was interesting that you've sent it to regions, but to my knowledge, it has not percolated down to Trust Chief Execs. And I'm looking forward to reading the slides, and I'll certainly pick that up with our regional Director of Workforce in North East and Yorkshire. The slides about the discrepancy of grades in Agenda for Change grades is absolutely characteristic in the trust I work for. And I think the key to this is, finding people to appoint to the senior grades is very difficult, because what we, in my view, need to invest in are the colleagues in bands 5 to get them to be band 6s, to be band 7s, then to be matrons. If I just use the nursing workforce, but similarly in management roles and other roles. And we've been joined, we've done partnership programs with the RCN leadership program for our band 5 nurses who have an ethnic minority background. And we are beginning to make accelerated progress actually in changing the profile at band 6 and band 7. But it is this level that we absolutely need to invest in. I think some of it is people do not have the confidence. They've been knocked back so many times. And it really is about helping people have confidence that these types of jobs are for people like our colleagues from ethnic minority backgrounds. And we're running master classes and so on of how to write an application form, the supporting statements, how you prepare for an interview, all of these things that we are doing to try and overcome the sort of self-limiting issues based on their life experience or work experience to date. In beginning of 2019, I think it was, we hosted a BAPIO conference, and I attended that again on a Saturday morning like this. And until then, I'd never heard of BAPIO, and some of the slides and statistics were presented there, and it was just completely shocking. And I'm pleased to say we've now formed a partnership agreement with BAPIO, and we're jointly working with colleagues from BAPIO to develop an induction program for doctors joining us from overseas. And part of that induction program are about sort of the customs and cultures of the UK in terms of non-medical factors, that to help people adjust to the way we do things, as opposed to the cultures where they have lived before joining us. And the trust I work for, it's still a pretty challenged trust, as Stephen will know, and in the annual staff survey results published in 21, the EDI domain was the only domain that we were above average, I'm pleased to say. So I think some of these things are beginning to change the way our staff from ethnic minority backgrounds and other protected characteristic backgrounds are beginning to believe that we are serious about our inclusion program in the trust. Thank you.
Thanks. So may I ask my distinguished speakers from the morning, what they would give the suggestion, what in addition to talk to our NHS leaders who can really make the difference on the to increase diversity? Because there was a report I saw in June with from NHS Confederation regarding strengthening NHS board diversity, and which has some suggestions which included limitation of tenure and and how to create stretch programs and how to help people. Is there a room for having something like this, some recommendations for increasing diversity in clinical leadership? Because from what I see around in our region, if you look at clinical leadership, although as my trustee executive Peter Redding said, that most of the staff is from ethnic minority in Yorkshire or North Lincolnshire or Lincolnshire. But if you look at the very high clinical leadership, maybe we don't see the diversity that should be there. So are there any suggestions that Anton, John, Roger, Mala, do you want to give with regards to that? How to increase diversity? Yes, Anton.
Thanks very much for the invitation, and thanks. I mean, it's really, I think, one of the challenges of sessions like this is that you have colleagues like chief executives who have joined us who are insightful and who are eager to act, and I guess it's the unconverted who we need to reach to. So I think some way of engaging that, and if this is a way of doing that, that's great. The clinical leadership, I think, is a really important point. We've just done a little bit of analysis to ask the question. I was really provoked by what you said, is if different communities have been affected by COVID, the way the BME community would have acted differently, and we looked at it in a slightly different way. We looked at London as an area we could look at the data on quickly, at the makeup of the gold commands that were in the London area, London trusts, of the 36 London trusts, and it was an interesting thing, depressing thing, that it is about something like 10 or 11% only of the Gold Command members in the various trusts put together were from a BME background. There's only one individual with a disabled background. So I think it tells you something about why representation matters, because there would be a voice saying, have you thought about? So it wouldn't be to dramatically change things necessarily, but there would have been a sort of somebody just putting a brake on the automatic default of, oh, we'll get the bank staff to do this, we'll get those porters will do the ferrying, that's fine. Somebody would have had a question. So I think that it's important. Representation runs deep. One of the other things we're showing is that organizations which have good representation at board level have also had the best uptake with vaccine, not just for the BME staff, but for clinically vulnerable staff and all staff. So I think we mustn't, and some of these are very practicable actions. We're not asking for dramatic things. So maybe creating a talent panel of individuals in a region who are potential NEDs and to join a board, so that if a trust says that we haven't got any, or we find it difficult to access colleagues with particular characteristics, there's a panel of colleagues who have expressed interest, and that they can be shared, in inverted commas, to use that. So I think there are some very practical things. There's developmental bits that the CECOL group are doing, should tap into. So I think it's a question, I think, trying to link up. I think if there's a role for the national team, it's to try and point where the resources are, rather than necessarily duplicating things. So yeah, lots of things. For me, an absolutely fundamental first step is leadership accountability. The leaders you have here are exemplars, and we have to just try and extend that message to all the non-converted.
So can you hear me? Sorry,
Yeah,
I'll
yes,
take
yes, please.
no, let Marla come in first. I'll speak after Marla. I'll speak after Marla.
Okay. Well, thank you, John. And Ahmed, it's a really good question. I just have two quick observations. One of the things that Sir Malcolm Grant, when he was chair of NHS England, said, in 2014 he was the chair of NHS England, and when the workforce race equality strategy was beginning, and he said, Marla, you're absolutely right. I go to UCL. I sometimes go into an undergraduate classroom, and I see a sea of, ethnic minority faces. But then I don't seem to see them at the, in the leadership teams. And it just occurred to me that there is this issue of leaders only ever wanting to appoint people who look like them and who they're comfortable with. And I think the ICSs give us an opportunity, if people like yourselves, leaders like yourselves, were to do as Anton was suggesting, take a list of people who put their names, prepared to put their names forward, and say, handhold us, and we will lead some of the ICSs or be part of the top table of ICSs, and test them out. They may not speak the way you expect them to, and they don't perhaps exactly follow the style of conversations that you have, but they bring a lot of wisdom. And in the clinical realm, one of the things that does intrigue me, and I know I mentioned this to Sir Malcolm, was that most chief executives, most leaders, do not realize that amongst the international medical graduates, you have a huge group of people whose fathers, brothers, sisters run entire hospitals in places like India or Pakistan. The resource constraint, environments in which they run hospitals is extraordinary, and they know an awful lot about innovation, and yet when chief executives are a doctor who is thought not to be of director material, just there, a jobbing doctor, and yet if they're only viewed a little differently and given the encouragement and a little bit of support, you might have some extraordinary diversity and very enriched innovation and planning within your systems, if one could just look beyond those stereotypes.
Thank you, Amala. Sorry, before you come in, I have to come in here. This is exactly what I think, frankly, because if you go to an interview, a person like me, I can't articulate as well as people over here are. English is my second language. I might think differently. I might think the same. I might thinking the same what you are, but I may not behave or articulate it as well as Martin did. And it puts me at a disadvantage in any interview I go to. People don't look beyond. What I can understand is that if I have been on interview panels on the other side, that you have to ask the same question to each candidate, and then you have to look at the answer. Why don't you look beyond it to see what is the background of that candidate is, what that candidate can bring to that job? This is not fair. I don't think so. It's in fact, this is not positive discrimination. It is in fact negative discrimination, because you are posing the same question, but you don't look at the background of the candidate. You don't look at but can he articulate the answer the same way? So when you're sitting on the same, you get to the same frame. Oh yeah, he answered the question better. Let's give him the consultant job. But you don't think of it that this guy came to UK 3 years back. He doesn't know the culture, but he still has achieved this in 3 years. So give him the opportunity what he might achieve in the next 10 years. So I absolutely agree with you. But like I said, we need vital eyes so that this happens. It's like, all right, me and you talking about it. Sorry, Chan. Sorry, I had to come in because this is exactly what I think.
No, it's really important. Oh, I was going to say that I think that when we look at leaders in NHS providers, that's whether it's chief executives or whether it's medical leaders, which is very relevant to the doctors I represent, I don't see that when people are appointed, the issue of whether they actually believe in and value equality and diversity being the question they're asked at an interview. And in my view, that should be probably the most important question when a chief executive or a medical director is appointed, and to really explore whether they understand the issues, but more importantly, whether they understand the positive benefits of diversity and equality. Because we know that any provider, and we've got the evidence there, Marla will give you the evidence, that providers, NHS trusts that are built around diversity and equality literally provide better care. The staff do better, the care improves, people are less likely to be off work, and work that Roger's done. But that's not being asked. So I do think it's about leaders actually believing in it, which needs to change. And the second, Martin, I was very impressed that you're doing this induction work for IMGs, but it should not be left down to your trust and BAFI are doing this. And Marla and I have spoken about this. This needs to be a duty of our nation. When doctors from other countries come here, we have a duty of care that they are looked after, because they are actually providing a service and a health service that would collapse, literally collapse, if they weren't here. And instead, they come here with a totally inadequate induction, and it's left to Martin and others to try and find a local solution. It needs to be absolutely a must-do. And that isn't just a short course. It's about the providers understanding that no one can adjust in a weekend course, and make adjustments, show understanding, proactively reach out in your first year, providing continued mentorship support. Are you okay? Do you understand this? Is there anything more I can do about it? If you run into difficulty, the first thought should be you may have gone into difficulty because you didn't understand the system. And that also requires a cultural change I mentioned earlier, more widely in the NHS, where the system is more open and allows people to speak out and are not afraid of blame or afraid of impact on your career progression. Because structurally, it's going to be ethnic minority doctors and overseas doctors who will be the most affected in any system that starts shaming you or blaming you. So these are real challenges, and I believe that these cultural changes won't come with a CQC inspection once every 3 years and as some tick box of showing that's part of the solution. Accountability is part of it, but you really need cultural change and have people working and leading the NHS that believe in this agenda and make sure it's a positive force of good.
Yeah, may I just say something quickly? I completely agree with what you said, Chand, and I just want to come back to the point you were making, Ahmed, that treating everybody the same is just going to prolong inequalities. You know, the point that you made about asking exactly the same questions to every single candidate and not exploring things further, you know, we'll just prolong the inequalities that exist at the moment. It won't solve it. It is about treating people differently so they have the same opportunities, you know, for good health, career progression, or whatever it is. And so I just wanted to expand on the point that you made.
Let me just make a quick observation on this debate. Number one, the data is telling us that even when our colleagues get shortlisted, they're not likely to be appointed. So equally competent people are coming to interviews and not being appointed. What's that about? In one of my observations as a chair of a appointment panel, and when I was naive, what happened at the end of the interview was the white consultants started to talk about the person they preferred before we'd even had a group discussion of who should be appointed. I stopped that, and in future ones, I led as the chair to say, right, what's the observations? That's one. Number two, the question of equality should not be what do you understand? It should be what are the inequalities in the NHS? And you should get two answers, one about inequalities in the workforce and one about inequalities in patients. Then the supplementary questions, the killer one. We should then be saying, in your last job, which inequalities did you change and move? I have not had many successful answers to part two. I even had a black non-exec director who'd been in the NHS for 8 years, not able to give me a single example. That's not normal. Normally, the diverse candidates can give you loads of examples. The other myth I'd like to dismiss is I've been working with one particular board. I'm not going to reveal for embarrassing them. They are all white board. They're going from good to excellence around equality and diversity. And I will share that case study with Anton because it's a really good case study about authentic leadership, value-based leadership, where people really want to make a difference. And the other comment I just want to make while I've got the floor is this is not about fixing people and giving them more training and more development. This is about us understanding the value of diversity, the value of skills and experiences people bring. My board is one of the most diverse, and I'll just finish on that. I have an ex-chief exec director of nursing. I have a local authority deputy director. I have an ex-private sector director, all are BAME. They weren't hard to find. These diamonds exist on the street. Just go and pick them up. If there were diamonds and you could cash them in, you would do. We tend to make excuses that BAME quality individuals do not exist. They bloody well do. Sorry.
So, thanks, Victor. Roger, do you want to say something?
If I may, I just go back to an earlier point. So Jagtal's just said it's not just a case of fixing people to get them better. I think there's a role in the way that a couple of colleagues have described for giving people more confidence. But the evidence says that there are two obstacles. One is that the whole at each stage of the recruitment and career progression cycle, you need to pay granular attention to the way that bias creeps in. There's a wealth of research showing at every stage, from the point at which how you design the job, through to how you shortlist, how you run appraisals, how you score, what selection method, and so on. But there are one or two particular things. So we shouldn't just focus on the interview process. There's one particular thing that every trust should be doing, and where it's been done, it's made a difference, is stretch opportunities, acting up, secondment, involvement in projects is the most important way in which people's career progresses. And it's time, I think, to stop the tap on the shoulder as the way of accessing that. We should be monitoring who gets those stretch opportunities in the same way that we should be monitoring job access and appointment processes, and we should be holding organizations and senior managers to account. There should be an expectation that over time, on average, the likelihood of Black and minority ethnic colleagues accessing stretch opportunities should be no less than that of other people. And if it is, it needs to change. And that should be done initially by supporting people, but eventually, as with any other KPI, it's going to change. And that's particularly, my last point will be related to that. That's particularly goes back to the point that somebody said about the middle managers, the frontline managers. Most decisions on discipline and on recruitment are made by band. In the case of Agenda for Change people, they're made by frontline managers on band 6, 7, and 8A. In medicine, they're made by managers. It's not the top managers on the whole. It's more junior medical managers and doctors. And they need to be engaged with and held to account at the same time. So the expectation should be clear, the consequences of not over time changing those data, but they also need support because they're often the people who get beaten up from all directions. So there are some really simple, practical things that people can do, as well as other things. So stretch opportunities and pay a granular attention to the way bias creeps in at every stage within the recruitment and career progression cycle.
Ahmed, could I come in?
Of course, yeah, of course, Professor.
Can you hear me? I just want to change the to a different emphasis in a second, but just on what we're talking about here, essentially about valuing difference and so on. It's the enormity, isn't it, of the cultural shift. There's been a massive shift. You know, Marla was talking about this because of the commitment back to 2014. So we should celebrate what's happened. But thinking of my experience in many years of running hospitals, you know, people in the hospitals, frontline staff, wouldn't think 2 seconds about challenging somebody for smoking on the premises. And that's the sort of place that we need to get to in relation to some of these issues. And that takes me to the other issue, which is, I am going to quote from, as I said, I was shocked by the LMC report in the Humber. And remember the Humber, the deprivation index in Hull is 20 points above the national average, and in North Lincolnshire it's 11 points above. So you're talking about this not just in the context of the BME community, but a much broader challenge. But this quote here, I think my worst experience of racism is when racist patients' comments, whether intentional or not, are brought to another member of staff who feel they owe no responsibility to correct or condemn these statements and simply honour patients' racist demands. This is probably the worst of it all, as it not only affects one's morale of the job, it also taints your perception and relations with colleagues. Silence, a British expression of politeness, is then perceived as tolerance and support of these racist comments. Now, I'm sorry for quoting all of that. That's such a powerful quote. Now, my issue is, back to the opportunity around ICSs. ICSs aren't just about the NHS. They're about the one workforce for the whole area that you serve. So in terms of these policies and some of the practical things that Roger's been talking about, I think our job is to try and integrate those approaches across all the sectors of health and care. And the other thing that I'd be really passionate about is ICSs are in danger of becoming bureaucratic organisations if we're not careful. But actually, they should be campaigning organisations. We've got 28 organisations that make up our ICS. What a powerful voice! So when we start thinking about the messages that we want to give, then we should be doing that. With my third point, which has really underpinned this conference, with really good data about where to target, who to target, and use the same campaigning zeal that we use in other areas in our health and local government activities. So, you know, back to I suppose my headline message is we need to see ICSs as a big opportunity in this regard.
Absolutely, Stephen. But there's also a big danger with this ICSs as well, because if it may even lead to increase in health inequalities. You know, recently, you know, if you're looking at what we say we are not centralizing services, but if services are moving from South Bank to the North Bank, then if you're going more towards different way of working, more towards remote working, and we do work in one of the most deprived areas. Grimsby's got one of the deprived areas. Broadband, do we know that people have broadband there? We're doing these virtual clinics. And so there's a danger as well when we're looking at developing services as well. If we do not have a strong voice where the decisions are being made, who look into these things and who raise these issues when these decisions are being made. Similarly in clinical leadership as well, if you're going to join big departments that are becoming bigger, or single clinical leadership running services across, I give the example where I work, South Bank and North Bank. Do you think the diversity will increase? Our danger, my fear is it will always reduce. You will have probably 20 consultants in a department who are from ethnic minorities, but the clinical lead is probably not from ethnic minority. So it might be a chance to improve things, but there's a bit of a danger with that as well, if you're not careful. Sorry, Mala, you want to say something?
Thank you, Ahmed. I'm very interested in the point that Professor Eames just made, about the whole, what the role of ICSs is. And of course, coming from a public health background, I'm delighted that ICSs are happening, because they take me back to an era when things actually, local government and third sector and the NHS actually seem to work far more closely together than they have in the recent past. One of the issues is also about education and an ICS public education role, because we also know that there's a linear relationship between the Brexit Leave vote and anti-immigrant sentiment. And, I really feel for my international medical graduates, and indeed UK Black and minority ethnic graduates working in those areas. And I know from having been a bit of an agony aunt all these years about the extent of the abuse they have to take. And it's particularly stark in those sorts of areas. And the ICS has got a huge obligation and I think an opportunity to educate the public about just the benefits that these people bring, the value of NHS staff as an employer in the area, and ensure that actually it's a win-win, because the public end up getting services, and of course the staff too then have a better experience of working in those areas.
Can I just come in for a second? 1 second, I'm not going to take too much time. ICSs are going to fail in their diversity of their boards. I predict that now. It's every restructure of the NHS has led to a worsening position for diversity. I predict it. I hope I'm wrong. I hope Marlo's right. I also think ICS's size of organizations and span of control is going to lead to a widening disparity and inequality. I hope I'm so desperately wrong, but this is my big fear, that the ICSs, some of them are going to be too large to make a difference, and most of them, 90% of them, are not going to be diverse enough, and many of them will lose the connection with the public and the patient. That's it. I know I said in my presentation, be optimistic, have hope. This is something I'm seeing as a nightmare scenario for ICSs.
Peter, I can see you smiling, so I think you need to comment here before Professor Eames probably gives a rebuttal.
All I would say is I think what you're saying, Jagtar, we've had this exchange elsewhere, is really important, as is what you were saying before, Ahmed. Let's face it, but at least, and I'm old enough, like some other people on this call, I won't name, to remember the previous 7 reorganisations of the NHS. So what I would say to you, with my glass half full, is there is a really significant risk. But then again, we've probably got a generational opportunity to make a difference with ICSs. So so if we can't do that in this context and in some of the others, then we will fail. I agree.
Peter, do you want to come in?
Yeah, can I come in and make a different point? I think Jagtar has raised a really interesting challenge about ICSs, but I won't go there. Can I raise a different point? It's just, this is a BMA conference, and that probably most of the audience are doctors. Conscious also of the huge role that doctors have to play in leadership in NHS providers. And I wonder to what extent there's an opportunity here for collaboration between the BMA, leadership of trusts and organisations like the FLM to look at how we can actually grow more leaders, medical leaders from BAME backgrounds. I mean, in my trust, we have 6 original clinical directors. I'm proud that 5 of them are from BAME backgrounds, and we're interviewing next week for a deputy medical director. All the candidates on the shortlist are from BAME backgrounds. So we are making some progress in interest, but as I said earlier, 2/3 of our doctors are BAME, so it'd be shameful if we didn't. But I think there is an opportunity to exploit the leadership role that doctors have in organisations to really grow that medical leadership. And there's an opportunity to collaborate, perhaps much more than we've done in the past.
John, do you want to respond? You're mute.
I absolutely agree with you. And in fact, the BMA has, I've spoken recently at a FMLM, that's the Faculty of Medical Leadership, about the importance of leadership. And we also have a medical managers committee in the BMA. As I said earlier, I think leadership is key by having the right diversity of leaders, but regardless of diversity, having the right leaders who absolutely get it, that you need the values of diversity and equality as a positive in its own right, that really understand that is what we need. And remember, there was a question earlier on about the tribunal outcome with the GMC just this week. Actually, medical leaders are vital when it comes to issues around complaints, when it comes to difficulties a doctor has. A good medical leader will understand it at the earlier stage and prevent things escalating. And in fact, a poor medical leader who doesn't understand, who doesn't value diversity, actually may not realize how much they are contributing unwittingly to the progression of a complaint that then leads to actually a doctor's livelihood and mental state becoming so devastated. So this isn't just some soft issue. This is about really having leaders that can look after the health of doctors so that they can actually look after patients. And from a BMA perspective, I would welcome doing some work, or the association doing some work with trusts and actually providers within primary care, which is more difficult because GP practices are individual units, but really doing some more work in that area. So if anyone has any ideas, happy to have that dialogue.
Okay. So
apologies, can I just interject here, because it's an important comment that's been raised by everybody here, because I've been looking at all the questions coming in on the chat here, and a lot of questions have been about how BAME medical colleagues can climb that leadership ladder within their organization. And another point that's been raised is actually how reflective are the executive boards of the trusts we work at, reflective of the people that work for them and the communities they serve. So, I mean, we've got 4 chief executives here, and can they really say to everybody here that their executive boards are reflective of the people that work for them or the people they serve? Thank you.
Short answer from me is no. Looking at the statistics across Humber Coast and Vale, about 1% we're talking about currently.
Yeah, well, that's the reason of having this meeting, but Martin, do you want to come in?
Yeah, I mean, again, you know, as Stephen said, the answer is absolutely no. The issue is that there, as I previously said, it is about investing in the development of people on lower grades so that they have the right experience. You know, I think Roger's point about developing people through experience is absolutely the right measure, but there isn't enough people, you know, who yet got the right experience, you know, to be a credible applicant for many of the directors' posts or indeed chief execs. So it is improving, as you know, but but that's only in a minority of trusts. You know, do they have an executive team that reflects the diversity of the workforce?
So in my trust, 1 out of the 10 of my executive team are from a BAME background, which, given the actual composition of the population of Northern Lincolnshire, which is predominantly white, is actually over-representation, but I'm not proud of that. So this has got to change. But I think Martin's right. What we've got to do with promotion in professions like medicine, the AHPs, more managerial grades, we've got to find a way of bridging the gap from the bands 6 and 7. That's where the block occurs. And how do people break through that? So I can't appoint a new, BAME finance director when no one applies who is shortlistable BAME background. Yet there are really credible BAME accountants at a lower level. So how do we bridge that? So I think that's a task for us as leaders. And I think support from the Leadership Academy on this, but also from unions like the BAME and Unison would be really helpful.
Thank you. Can I just ask a final question? Probably, we've got so influential people here. What would it take for NHS England or NHSI to give reducing health inequalities the same weightage as they give to financial balance or waiting times? We have trust in special areas for financial, problems or for, other reasons. But what would it take? They would give health inequalities the same weightage, or what we can do. Maybe Professor Emmanuel has got any suggestions?
Thanks. My tuppence worth would be that we have to make it a no-brainer. So we have to show that actually everyone on this call recognizes the truth of the fact that when you do EDI well, not just about race, we know that we can already show things like, say, vaccination I mentioned, but we can also show a relationship between that and patient safety events, between cancer targets. So it's almost just making that explicit. So rather than it being to say the system is fundamentally against people, the reason we have particular characteristics is because they need to be protected. But the irony is that in not protecting those individuals with diverse backgrounds and experiences to speak to, we make our systems break more. So fundamentally, it's about trying to make the people who feel it's like an extra obligation, oh my God, you guys are back on my case about this, oh, another little res data, another report, give me a break, to actually say, look, it's in your interest. So NHSEI's role, I think, is to make, and I keep coming back to it, and I apologize for being a broken record, it's leadership accountability. Working with CQC and all that, that's a kind of institutional thing, which the kind of air covers, it does describe to me, that NHSE can work with. But I think the two bits it has to fight its battles on are leadership accountability to make that, let's say, a no-brainer, and then do the big piece with institutions because it has the power to do so.
Can I chip in? I think it's not so much NHSEI as the CQC. And
I was going to say that.
Yeah. Chief exec's point of view, NHSEI has its job to do, but the people who scare you are the CQC. And if they bedded into their reviews a really thorough review of EDI in every inspection they did, trusts would start pulling their socks up very fast.
Yeah, absolutely.
Yeah, could I just add to that? I heartily endorse what Peter's saying, and I think Martin would agree. And having lived in your world for a long time before this one, I absolutely get what's being said. But back to my theme of opportunity, the CQC is at the moment, it has a strategy out which it suggests very strongly that the modus operandi will change. And I've long felt that really, when you're trying to resolve issues like this, what you need, which picks up Anton's point, is a compact between the collective leadership of systems and places to make these sorts of changes. And actually, what you also need to do, I think, is incentivize it. So when you say, what could NHSEI do? And in fairness, I think they are driving this in equal measure with the other key headlines you mentioned, but it doesn't yet have the cultural grip that some of those currently do within the way that we've traditionally run health services. So, but I think the opportunity is again around the collective action, around building positive incentives, and you know, organisations, the regulatory Peter, you mentioned the CQC, but there are numerous other regulatory organisations that could adopt and adapt a more, dare I say, enlightened approach to addressing these issues.
I would just absolutely echo that. I don't think the CQC is the right forum. They have far too many metrics that they measure. Equality, diversity is in those metrics, it just disappears. I've been calling out for the Equality Delivery Council and NHSIE to carry out a thematic review on equality, diversity, inclusion, looking at the two metrics of workforce and patients in the way that the police did it following Stephen Lawrence and the fire service did it following Stephen Lawrence's death. A thematic review, root and branch, led by NHSIE with clear recommendations that are set for all trust and providers to comply with. CQC is the wrong forum. We've been barking up that tree for so long now. We failed because they've got too many metrics to measure, and many of their inspectors do not get this issue either. So we need specialists like Roger to come in and work with NHSIE and do that metrics. Roger's report, Snowy White Peaks, is a demonstration how a thematic in a single area can make a difference.
Amit, you asked the question, what would it take for NHS England to not focus on finances and focus on EDI issues? Well, I think that's the problem. NHSEI and more importantly, government, the health secretary, should understand that the most cost-effective way to run the health service is driven by an equality and diversity agenda. They're not competing. In fact, the most expensive way to run your health service is having a unequal workforce that actually suffers all the impacts around inequality and the lack of productivity. So in fact, unless that penny drops, you know, so it should not require CQC to go. It should be a must do because it's the best way to run your health service. And before we finish, I just want to, as BME Chair of Council, just say thank you to you personally, Ahmed. This event was your brainchild several months ago. You have brought together amazing expert speakers, a fantastic morning, and also want to thank the officers of BMA Yorkshire Regional Council. Really, the BMA at its best. So thank you very much.
Yeah.
Thank you, Sean. Your words mean a lot. I think Roger wanted to come in before we finish.
One sentence, and I will endorse that, and apologies for not being earlier. I was speaking at a conference in London. I think there's one question that chief execs can usefully ask those putting forward proposals to mitigate and hopefully remove discrimination, and it's this: could you talk us through, as you would for a clinical challenge, what's the evidence that what you're proposing has a reasonable likelihood of succeeding? And the reason I say that is because many of the things that the HR community, I don't think there's an HR director on this, so I can safely say this, but I've said it at their conferences, many of the things that HR directors have put forward with good intention actually were never likely to work. There was no evidence underpinning them. There is lots of things that evidence does underpin, and I think asking that question forces people to think, right, let's make sure that what we're going to do is actually going to make the difference we want to make.
Absolutely, thank you. I think we're just about in time, so I would just like to express my thanks to everyone who have found time on a Saturday morning in July. Although it's not sunny where I am, but maybe sunny where you are, and people have left their golf sessions to come here. So thank you very much, and hopefully we will have more of these type of you can say events where we talk about solutions rather than just presenting data, which we all can see, we all know. And once again, thank you very much. And I would like to say thank you also to my deputy chair Shirley, who has very ably in the background looked at questions, and to Elaine, our BMS senior IRO, without her help, this conference would have been possible. And also someone in the background who's still listening, our technical support, Sabs. So I've seen her once, but I've heard her a few times. So thank you for your support. And thank you. And hopefully we'll have another event like this in the near future. Thank you. And have a very nice rest of the weekend.
Yeah.
Thank you.
Right.
Thank you.